I hear the announcement. Okay, we're going to start the webinar, Michelle. So maybe a 5 to 7 second countdown, then you can dive in.
Great. Good morning, everyone. My name is Michelle Johnston, and I'm the Program Director for Dementia Initiatives with the California Department of Aging. Thank you all for joining us this morning for our Alzheimer's Disease and Related Disorders Advisory Committee meeting. We're going to give a few seconds for everybody to enter the meeting. Fun fact, it is National Brownie Day. So if you're a brownie fan like I am, maybe you can find one of those for after the meeting or on the lunch break. Could we advance to the next slide, please? We're going to go over just the quick meeting logistics. So there is an option to join by smartphone, tablet, or computer, or audio only. So you've all found us if you're in here, so thank you. There is live captioning accessible in Zoom. We also have American Sign Language interpretation. You should be seeing those folks as well. And then the recording, slides, and transcripts will all be posted on our Cal HHS Alzheimer's Disease and Related Disorders webpage after the webinar. It's going to take us a couple days to get all the slides up, but everything will be there. We will have public comment twice during the meeting today, so once this morning and then once this afternoon. If you have public comment that you would like to provide to the committee, if you're joining by webinar, so if you're on the Zoom, please use the Q&A function to ask a question or select the raise hand icon, and those are both at the bottom of your screen. The moderator will announce your name and unmute your line for you when it comes time for you to make public comment. If you're joining by telephone, please press *9 on your dial pad, and that will raise your hand, so we'll know that you would like to make comment. And then when the moderator gets to you, they will announce the last 4 digits of your phone number and unmute your line. And so then you can speak at that time. And so at this time, I'd like to turn it over to our committee chair, Catherine Blakemore, who's going to do the welcome and introductions. Thank you, Catherine.
Good morning, everyone. It's so nice to see all of the participants on the committee, as well as we have a really terrific panel today. And thank you so much for joining us and sharing your expertise. I want to just take a couple of minutes to note things for the meeting. First is towards the end of the meeting, we're going to sort of have an opportunity for everyone to identify topics they're interested in discussing in our next set of meetings starting in 2023. We used that approach this year, and this panel presentation today is the result of one of those ideas that came out of that from Dr. Mobley and others. So I think it's been a very successful approach to let the committee say what they're interested in and to identify topics. So please, just as the morning goes on, just think of ideas that you might be interested in. We have a couple of carryover items from last year. Dr. Canio had talked about wanting a presentation about ability of people to make decisions. What are alternatives to decision making? How does one determine what an individual's capacity is for decision making? So we'll look into doing that as one of the topics for the next year. And Derek Lamb had identified social isolation, and Susan has added Derek to a group that is ongoing with that. That will be starting, I think, that discussion after the first of the year. So I'm sure we'll also get reports about that. The other thing I wanted to note is that Andrea Robert, who is one of our fabulous members of the advisory committee, is featured in this month's Alzheimer's magazine. So congratulations, Andrea, on that. And Michelle Johnson is trying to get a PDF version of that article so that we can circulate it to everyone on the committee in case you don't otherwise get it. So those are my just quick updates before we start anything. But I would just like each member of the committee to briefly introduce yourself so that people just remind us who you're affiliated with, and if you have a very quick update, feel free to say that as well. So let's have Meg do that first. Is Meg on the call? Maybe not yet. Okay. Is Julie Solier here? Not yet either. I'm not
Nope.
doing.
I'm
are.
here,
Perfect.
Catherine. Sorry,
Yay,
I
thank
actually
you.
joined a
Sorry,
couple
hard to
minutes
keep
late.
track of all these the little key boxes.
No, understood. Morning, everybody. I am Julie Soulier. I'm an assistant secretary at the California Health and Human Services Agency. And I have oversight of the Department of Public Health, as well as the Emergency Medical Services Authority. And I cover all things kind of policy and budget for both of those departments. Nice to see everybody.
Terrific. Thank you. Dr. Farias.
Hi, I'm Sarah Farias. I direct the California funded Alzheimer's Disease Center at UC Davis. I'm a professor at the in the Department of Neurology at UC Davis. And I think my role here is to represent the 10 CADCs across the state. So thanks for having me.
Welcome. Is Pam Montana with us this morning? I don't see her yet. Andrea Robert, good morning.
Good morning. Good morning, everyone. Thanks for that plug-in in regards to the Alzheimer's Association article for the winter 2022. It was a really good article in regards to living well with mild cognitive impairment. Again, my name is Andrea Robert. I live in a small town called Claremont, California. I am a mom, just found out I am a grandmother. And I advocate a lot for myself and other people in regards to resources and services to allow us to live a better life living with these cognitive disorders. Thank you.
Thanks so much. Dr. Thompson, are you with us? Don't think so yet. Dr. Mobley, we see you. I'm looking forward to your presentation in a bit too.
Thank you very much. Professor of Neurosciences, UCSD, and I'm looking forward to speaking with everyone.
And Todd Shetter, looking forward to your presentation also.
Good morning, everybody. Todd Shetter, I'm the Chief Operating Officer and partner at Active Care Living, and we're looking forward to kind of introducing everybody to what we're doing down in Southern California.
Also looking forward to that. Celine Regalia.
Good morning, everyone. My name is Celine Regalia. I'm the Executive Director of Collaborative Care here in Napa. We have a hospice program, palliative care, adult day health. We're an Alzheimer Daycare Resource Center, and so I'm the Alzheimer Daycare Resource Center representative.
And Dr. Canio.
Good morning. I'm Wen Canio. I'm a psychiatrist and geriatrician taking care of people with dementia every day. Also the dementia care clinical lead for the Northern California Kaiser Permanente and a mental health representative for this group. Thank you.
Nice to see you. Is Barbara McClendon here?
Yes, I'm here.
Excellent.
I'm with Alzheimer's Los Angeles. We are an independent community-based organization, and we have robust array of services for families in our community. And we also do a whole lot of public policy work. I'm our public policy director, and I'm looking forward to today's conversation. Thank you.
And of course, we're happy to have Susan DeMarios with us, who's the director of the Department of Aging. And Susan, do you want to say anything? And then also just introduce your staff that's here?
Absolutely. Good morning, everyone. I'm so happy to be here and glad we're gathered together at the end of the year. And on our call today, we will be hearing from, so you've met Michelle Johnston now. We're just thrilled beyond belief to have a dedicated subject matter expert on Alzheimer's and dementia. You'll also be hearing from Tanya Bautista a little bit later in the program, and I believe other staff are joining as well, listening in.
Thanks so much. And with that, I want to just ask that we approve the minutes. So we have that out of the way. The minutes were in the package for September. Are there any discussion or correction of the minutes? Okay, not hearing anything, then we would have a motion to approve the minutes.
I move to approve the minutes. This is Barbara.
Thank you, Barbara. Is there a second?
Second, Todd.
Thank you, Todd. Any other discussion? All in favor say aye. Aye.
Aye.
Hi.
Aye.
Any opposition? And are there any abstentions? Okay, the minutes are approved. So we have all the quick beginning business out of the way. And with that, it's really my pleasure to begin our presentation about Down syndrome and Alzheimer's disease. As I mentioned, this was something the advisory committee was interested in. And I want to just acknowledge Michelle Johnson's incredible work of pulling the panel together, both in a planning meeting and following up to make sure we had really terrific speakers on each of the topics that you see. And I've had the opportunity to meet many of the speakers, and I know they're just incredible experts in their field. So it's going to be a terrific presentation. The panel this morning starts with Dr. Mobley, who, as he noted, works at UC San Diego, but he's a distinguished professor in the Department of Neurosciences, and this is one of his areas of passion. I think he once described it was his work in this area. So we're just incredibly fortunate to have him both as a member of the advisory committee, but also sharing his expertise with us this morning. I recently had the pleasure of meeting Dr. Lucy Esralu, who's a senior supervising psychologist for the Department of Developmental Services. She works with the department looking at concerns for people with Down syndrome and dementia. And as she pointed out, dementia is not limited to people with Down syndrome. And so she's developed a lot of expertise in this area, and we're really grateful to have her with us. Lisa Rund is an RN and the Health Services Associate Coordinator for the San Andreas Regional Center, and been doing a lot of work and education in this area. So Lisa, welcome to you. We have both Todd Shetter, who's a member of our advisory committee, and also the Chief Operating Officer at Active Care Living, Residential Memory Care, and Kimberly Keene, who are going to be co-presenting. Kimberly is the Director of Program Development at Noah Home. So we're happy to have both of you presenting. And is Mark with us this morning yet? Mark, good morning. Is it, and I have not met you. Is your last name, can you pronounce it Lupe maybe?
Lupe.
Perfect. So
Thank you.
happy to have you. He's
Sure.
family caregiver. I'm going to provide a family caregiver's experience. So with that very brief introduction of who's on the panel, I'll just note, as Michelle said, that we have extensive bios of each of these individuals. They're posted on the website. I would, encourage you to look at them and delve deeper into the great expertise that each person is bringing. But with that, Dr. Mobley, we're going to turn the discussion over to you.
Well, thank you very much. What an honor to be here and to be able to talk about something about which I'm so, as you indicated, passionate. So what I'm going to talk about in the next few minutes is a topic that may not be on top of mind for many folks on the panel, but it's the fact that Alzheimer's disease occurs with extraordinary frequency in older adults with Down syndrome. Remember that Down syndrome was trisomy 21. They have a genome in which they have an extra copy of human chromosome 21. We'll talk about Alzheimer's and Down syndrome, but we'll also talk about the great hope that we have that we can, because of what we've learned about Down syndrome, actually prevent it. So with that, let me go to the next slide. These are my disclosures. I'm very active in the field of research in Down syndrome and Alzheimer's disease, and that's what these disclosures make clear. Then the next slide. So as an overview, I'm going to say that adults with Down syndrome face many challenges. The most significant is Alzheimer's disease. In fact, Alzheimer's disease is the leading cause of death for adults with Down syndrome. This condition is due to an extra copy of the gene for this protein called APP. If you have Down syndrome and you have 2 copies of APP because of a partial trisomy 21, you don't get Alzheimer's disease. But if you have 3, you get Alzheimer's disease. Now, there have been a lot of recent advances, and these are giving ideas about future trials to prevent DSAD. This is what I'll call it. DSAD is Alzheimer's disease and Down syndrome. And my last message will be that we really must enhance healthcare services for adults with Down syndrome to equip them for this oncoming opportunity to properly diagnose dementia and treat dementia and even prevent dementia in these folks. So next slide. So caring for adults with Down syndrome is quite challenging. Adults with Down syndrome experience a number of clinical challenges, and changes in brain function are quite frequent. If you go to the next slide, this is a cartoon about all the different systems in the body that are impacted. So notice that there is cardiovascular disease, musculoskeletal disease, hematological disorders, bowel dysfunction, changes in the shape of the face, sensory problems with hearing, with vision, troubles with respiratory issues, sleep apnea, and autoimmune conditions. All of these occur in Down syndrome with varying frequency. But every person with Down syndrome, child and adult, have neurological disorders, neurodevelopmental problems with developmental delay, psychiatric disorders in children and adults, and Alzheimer's disease in older folks with Down syndrome. Next slide. In fact, the most significant challenge that adults face is the emergence of DSAD. So let's talk about that some more, and then toward the end, we'll talk about what clinicians are faced with when they care for such folks. Next slide. So again, let's focus now on specifically Alzheimer's disease and Down syndrome. Next slide. Let's go to the next slide, please. So I looked at some recent data for the number of folks with Down syndrome in the USA. So remarkably, in 1950, the mean age at the time of death was 26 years. In 2010, it was 53 years. And in fact, by now, most of these folks are living to age 60. They're living longer because they have the proper care of cardiovascular problems and surgery as children, because their medical care is now much more rooted in the care of the family. So with that, with those interventions that basically are their right as human beings, they're living longer. The folks that are 40 years and older are those at increased risk for Alzheimer's disease. And so the next slide, I tried to calculate the number of the people in the United States that are at risk for Alzheimer's disease and Down syndrome. And I calculate that at this time, about 100,000 people are at risk for this condition, meaning that perhaps 10,000 are at risk for this condition in California. So this is a very large population. Of course, it's not as large as the neurotypical population with sporadic AD, but it's much larger than any familial Alzheimer's disease grouping, and really deserves our attention. Next slide. So what do we know about Alzheimer's disease and Down syndrome? We know that it's much more frequent and earlier. And there are varying measures of how frequent it is. But over the age of 65, the percent affected, it increases above 90%. I won't bother you with the diagnosis of dementia, but you'll remember that there are both cognitive and behavioral symptoms that interfere with the ability to function normally and are definitely a decline from previous level of functioning. Down syndrome with AD typically involves memory loss and changes in mood. It occurs at a median age of 55 years, the dementia diagnosis, that is. Next slide shows a very nice study from England, which shows you the frequency versus the age at diagnosis, and that median frequency is about age 55. Note that the cumulative risk by age 65 is estimated to be 90%, and over that, even higher. So it's a very frequent condition with very, relative to sporadic AD, much earlier onset. The neuropathological changes in the brain are very similar, if not identical, to Alzheimer's disease, and they're found in essentially everybody with Down syndrome by age 40. Next slide shows that they're the things that we talk about. Next slide. They're the changes that we talk about typically. So here's a view of the cortex of a person with Down syndrome or a typical person with AD, stained with a silver stain. And note that there are amyloid plaques, that there are neurofibrillary tangles. These consist of this phosphorylated version of tau. The plaque contains this A-beta peptide, A-beta 42. And less talked about, but very significant on the lower right, there are things called endosomes. These are little spheres within vesicles within cells that are important for degrading material and for carrying information in the cell. They're enlarged and abnormal, both in Down syndrome with AD and also in AD. Next slide. So interestingly, the genetics points to an increased number of the copies of the APP gene, instead of the normal 2, 3, as necessary for DSAD. There are 3 major papers that have talked about this, but let me focus on the Duran et al. Paper in 2016 from UC Irvine. Next slide. Here was a man, an elderly man with Down syndrome that was partially trisomic for chromosome 21. He had only 2 copies of APP. Between age 66 and 72, he had repeated neuropsych testing, neurological exams, amyloid PET imaging, and measures of amyloid beta in his plasma. His intellectual disability was mild, and serial tests showed less than a 3% decline in cognition. He was not demented. His PET scans were negative, and his plasma A-beta levels were lower than values for demented or non-demented adults with Down syndrome. This is all consistent with him having only 2 copies of APP. Next slide. At postmortem exam, his brain showed a single neuritic plaque. Compare his brain on the left with the typical ADDS brain on the right, and notice the multiple areas of brown staining, the little spherical collections and the little sort of more distinct, darker collections. That's the typical ADDS brain. He didn't have those. He had a single neuritic plaque, and the tangles that he had were just consistent with normal aging. So this is one more study that supports a necessary role for APP, gene dose increase, for DSAD. Next slide. We've been very interested in understanding how these changes might be modeled in mouse models of Down syndrome. And so next slide, we've looked very carefully in a number of mouse models. Note that on the left in the green is a cartoon of a human chromosome 21, and then right next to it, note those 3 broken up little segments, MMU16, MMU17, MMU10. Those are the mouse chromosome segments that correspond to human chromosome 21. And as a result of the fact that those genes are conserved in their order, it's been possible to make mouse models that really recapitulate the genetics of human chromosome 21. We've studied mostly the mouse, the circle there, DP16, 1YEY. I'll call it DP16. Next slide. What we found in this mouse, that there was an increase in the APP gene dose, resulting in an increased level of APP and its products. So next slide, very quickly, let me remind you that a gene the APP gene is transcribed into an RNA, an mRNA, that mRNA is turned into a protein, and that protein is processed. So here in the middle is the full-length APP protein, and notice that it is cut into two kinds of fragments, C-terminal fragments, C83 and C99, and C99 then in turn gives rise to that A beta peptide that's present in plaques. The levels of all of these protein fragments are increased by 50% in people with Down syndrome. Next slide. Next slide. Now, what we see in the mice is that there in fact is degeneration of neurons, just the same kind of neurons that are affected in Down syndrome. There's dysregulation of endosomes, and there's increased phosphorylation of tau. And interestingly, importantly, every one of these features requires an extra copy of APP. So the mouse models and the human models are both converging on an increase in APP as necessary for Down syndrome folks to get Alzheimer's disease. And critically, and maybe almost uniquely, we now have strategies that we can use to prevent these changes in their brain. So notice the APP gene going to the mRNA, we can block that with an APP antisense oligonucleotide. A small molecule called posifin can block the mRNA from becoming full-length protein. Various enzyme inhibitors can prevent that full-length protein, FLAPP, from becoming an APP-CTF. GSMs, or gamma secretase modulators, we can shorten those A beta peptides so that we can make them non-toxic. And finally, as you'll have heard, there are a number of companies that are producing anti-A beta antibodies, the most recent of which was discussed at the CTAD meeting in San Francisco. Moreover, we now have clinical trial networks that can carry out studies in Down syndrome, and we're using measures to evaluate changes in cognition and function in those folks with Down syndrome, and we can employ biomarkers that have been used in Alzheimer's disease trials. So the stage is set for a very exciting time to both understand and diagnose and treat to prevent Alzheimer's disease and Down syndrome. Next slide. Now, let me return to the challenge that clinicians have. Clinicians need experience in the management of adults with Down syndrome to address the problems that I've just talked about. In fact, Down syndrome with AD is not the only condition that can cause changes in memory and mood changes in elderly folks with Down syndrome. Caregivers need to be able to engage doctors and other caregivers with expertise in Down syndrome to define the problems and treatments, and the clinicians in turn must carefully consider the several possible causes of neurologic dysfunction, including memory loss. Next slide. I won't go through these in detail, of course, but sensory deficits, for example, hearing loss, metabolic disturbances, for example, B12 deficiency or undetected thyroid dysfunction, a coexisting mood disorder. Next slide. Sleep problems, seizures, pain, changes in mobility, changes in the psychosocial development, and other changes can all impact people with Down syndrome and mimic Down syndrome with AD. And so clinicians really must be acquainted with an expert in evaluating folks with Down syndrome to make sure they make the correct diagnosis and use the correct treatment. Next slide. We asked a little while ago, 2021, so what is the status of the clinical care of people with Down syndrome? We know that specialty centers improve care for patients with Down syndrome, but how many of those exist? And are the folks with Down syndrome that are adults being cared for properly and in such centers? So we conducted a national survey of staff of specialty clinics, and we reviewed online clinic listings, and we calculated the number of adults with Down syndrome seen, comparing that to the number in the country that I referred to earlier. Our analysis identified the percent of adults with Down syndrome who could have had their medical care needs met in a current specialty clinic. Next slide. 14 specialty clinics provided care for 4,000 roughly adults with Down syndrome. Reported gaps included limitations of existing clinics, the need for additional clinics, and health professionals with expertise in Down syndrome. Survey respondents' clinical capacity would meet the needs of only 3% of adults with Down syndrome. And online data for 25 specialty clinics, or 25 clinics that listed expertise for adults with Down syndrome, there was capacity for 6,500 roughly, meeting the needs of only 5%. So we're dealing with a care system that can deal with a tiny fraction of adults with Down syndrome, at least as regards clinics with expertise in this domain. Next slide. So additional clinic capacity is needed. We can now, I think, provide guidance to create additional clinics. We kind of know who should be on the team. We know something about the financial supports available, and we know something about the gaps in current clinical care. I think we need a much more robust clinical care network to meet the needs of adults with Down syndrome, and especially urgent is the need for clinics that can be expert in defining the onset or the occurrence of, the complications of, the consequences of Alzheimer's disease in this population, and really to bring on, to usher in a new era in which we'll be able to properly care for them, diagnose problems, and employ effective treatments early and perhaps preventatively. Next slide. So to overview, adults with Down syndrome face many health challenges. The most significant is Alzheimer's disease. An extra copy of the gene for APP is necessary for Down syndrome with Alzheimer's disease. Recent advances are really encouraging that future trials will be coming to prevent Down syndrome with Alzheimer's disease. And we must enhance healthcare services for the care of adults with Down syndrome and to equip them to properly deliver treatments that are proven safe and effective for preventing this condition. Thanks very much.
Thank you so much. Such good information to start us off. And I'm really happy to turn the next part of the presentation over to Dr. Lucy Esralou from DDS.
Yes, thank you so much. And Dr. Mobley, I very much appreciate your thoughtful and informative begin to this presentation. So we could look at the next slide, please. It's my privilege to represent the Department of Developmental Services today. DDS's director is Nancy Bargeman. And just so you know where we're located in the system, so to speak, DDS is one of the departments under the California Health and Human Services Agency. DDS contracts with 21 regional centers throughout the state of California. And they, in turn, the regional centers, contract with service providers who then provide the services and supports to individuals who are Lanterman eligible. Later on in the presentation, you'll hear from Lisa Run, my colleague, who is from San Andreas Regional Center, and she'll talk more specifically about regional center services. The state does operate some services directly, including some crisis stabilization services, an acute crisis home, a secure treatment center in Porterville Developmental Center. So just to give you kind of an overview of some of what the department has. Next slide. I'd like to talk to you a little bit now about our vision in the department, and it's that people with intellectual and developmental disabilities experience respect for their culture and language preferences, their choices, beliefs, values, needs, and goals from a person-centered service system made up of a network of community agencies that provide high-quality, outcome-based, and equitable services. Next slide, please. So individuals are found to be eligible for Lanterman services on the basis of a Lanterman Services Act, and it is at the regional center that they're found to be eligible. So California is the only state in the country that actually has legislation that supports lifelong services for individuals. California law defines developmental disability as a disability that originates prior to the age of 18, is expected to be lifelong, and is a substantial disability for that person. We usually recognize 5 categories of eligibility. One is on the basis of intellectual disability, another if a person is on the autism spectrum, another if the person has epilepsy, another if the person has cerebral palsy. And then there's a 5th category for those individuals that don't meet the preceding criteria that I mentioned, but actually resemble closely the needs of individuals with intellectual disorders in terms of their requirement for services. And I should point out, it is possible for an individual to have one or more disabilities. So for instance, a person with Down syndrome may have intellectual disability and a seizure disorder, or intellectual disability and place on the autism spectrum. You will have noted from the preceding slide that Down syndrome itself is not an eligibility category, but almost universally, individuals in our system are made eligible on the basis of their intellectual disability. So this slide just indicates that we are in it for lifespan services. So even before individuals may be found Lanterman eligible, we are involved with federal programs that offer early start services to children that have, young children that have developmental delays. We do have a relatively new category of provisional eligibility for 3 and 4-year-olds who need extensive services, but before they may be determined to be Lanterman eligible. And then we see people throughout their lifespan. Next slide, please. So this just gives you a 10-year view of the growth of individuals served, our population. So in 2012, we served 251,000 Californians, and with all types of intellectual and developmental disorders. And this year in 2022, we are at 377,000 and counting. Next slide, please. So this breaks down our consumer population in terms of their eligibility status. How were they found eligible for services? There are just a couple of things I want to point out about some shifts in our demographics. One is we have an increasing number of individuals who are found eligible on the basis of autism compared to 2012. Whereas in categories of cerebral palsy, epilepsy, and intellectual disability, we have a shift downward in terms of individuals who are eligible on the basis of those categories. Within the category of intellectual disability, about 20,000 individuals are those with Down syndrome. Next slide, please. So this slide looks at, from a regional center perspective, age, ethnicity, and residence type of individuals with Down syndrome. So you'll see, interestingly enough, only about 1% of our population is 65 or older. Most individuals are adults 18 to 64, and then the next sizable group are individuals 3 to 17. In terms of ethnicity, about half of individuals identify as Latinx or Hispanic. We do have 29% who are Caucasian, white, and we have 9% Asian, 4% Black. And then the interesting thing about residence type is 88%, that is a very large percentage of individuals live in the community in the home of a parent, guardian, or in a foster home. Next slide, please. So just a little bit about Down syndrome itself. Down syndrome is the most frequently occurring chromosomal disorder and the leading cause of known genetic, intellectual, and developmental delay. And most individuals with Down syndrome currently live typical lives in their communities, which is a change from last century. So in the 1900s, it was very common for individuals with Down syndrome to be sent to institutional care. As we Americans gray, so too individuals with Down syndrome gray, because individuals with Down syndrome are living longer, as indicated by Dr. Mobley. And that will lead to an expected increase in the population of individuals with Down syndrome over the next 20 years. So interestingly, my dates are a little different than what Dr. Mobley shared, but as of 1980s, the average life expectancy was only about age 28, and it more than doubled by 2020. The average life expectancy was 60. And of course, with longer life expectancy, you can see there'll be increases in certain conditions that we typically see as we all age. Dr. Mobley indicated a number of conditions associated with Down syndrome that might put people at risk for memory issues. Approximately 50% of individuals with Down syndrome have a congenital heart defect, which we think increases their risk for an early onset dementia. And then we have noticed a phenomenon that we have termed accelerated aging, so that individuals with Down syndrome are more likely than their non-Down syndrome peers to exhibit changes associated with aging at a younger point, in their 40s and 50s, as opposed to the typically aging population that might not show changes until their 6th or 7th decade. Next slide, please. So we heard from Dr. Mobley about the importance of chromosome 21, that Down syndrome is trisomy 21 with a third copy of that genetic material. And that gene is thought to produce protein that is key to brain changes associated with Alzheimer's disease. So approximately 70 to 90% of older individuals with Down syndrome will eventually develop Alzheimer's disease or related disorders. And we typically see individuals at higher risk after age 50. However, we do see individuals that exhibit signs of Alzheimer's disease in their late 40s. Signs of Alzheimer's disease are apparent much earlier in the population of individuals with Down syndrome. Talked about this accelerated aging idea. So you may see these changes in individuals 20 to 25 years before you might see the onset of those changes in the typical aging population. And also we see a decrease in functioning progressing more quickly among individuals with Down syndrome. Next slide, please. So I'm excited to talk to you about point out two initiatives that are new to the department and are relevant. One is the Aging Inclusion Specialist, and that's a leadership position that will provide us with subject matter expertise in the intersection between aging and intellectual and developmental disorders. This position, the person who occupies it, will inform us and help us develop policies, resource materials, trainings, and support, which are consistent with the Lanterman Act, also consistent with Governor Newsom's Master Plan for Aging and other federal and state statutes and regulations. We have a pilot beginning in 2023, which is a coordinated family support program. This new model will provide supports to adults 18 plus who are living in their family homes. And this is going to help support a principle that we have in the aging field of supporting aging in place, because it's going to help improve service equity and meet evolving needs of adults and their families without those individuals having to move from their family home. Next slide, please. So I would like to direct you to a wonderful resource that's published by the National Down Syndrome Society. It's a handbook entitled Aging and Down Syndrome, a Health and Wellbeing Guidebook. This really gives you ideas about aging with Down syndrome and definitely covers the idea of Down syndrome and dementia. Next slide, please. And then we have a number of links that we're providing for you when you get the handouts, the PowerPoint. Please follow them so that you can learn more about services through DDS. Next slide, please. I want to thank you for the opportunity to talk to you today. And at this point in time, I'd like to hand the program over to my colleague, Lisa Runn from San Andreas Regional Center.
Okay, thank you very much, Dr. Esrelu. And thank you all for being here today. I'm honored to take part in this webinar. As was said, I'm an RN at San Andreas Regional Center. And what I can do for you today is just give you a quick snapshot of what we do here locally. Next slide, please. So as was mentioned, the Lanterman Developmental Disabilities Services Act of 1969 established eligibility requirements for regional center services, and it outlines how regional centers work. And it says that people with intellectual and developmental disabilities have a right to services and supports to help them live the most independent and productive lives possible in the least restrictive environment. So that is our basic mission. Next slide, please. This map of California shows you the colored areas that the 21 regional centers cover. San Andreas Regional Center is located in the South Bay of San Francisco Bay Area. And on the left of the slide, you see that just kind of a simple breakdown of our basic services we provide. So to individuals, regional centers can provide diagnostic assessment, which helps determine eligibility for services. For the little ones, birth through age 2, we facilitate an individualized family service plan. These children, infants and young toddlers are in our Early Start program, which is early intervention in an effort to either prevent or mitigate the developmental disability. We also facilitate the individual program plan known as the IPP for those that are 3 years and older who have been made eligible for ongoing Lanterman services. And the key person at the regional center is a service coordinator. You can think of them as a case manager where they have a caseload of individuals that are eligible for services. Everything is based on the individual's needs. The individual program plan lays that out with goals and objectives, and then authorization for funding of the services through our regional center vendors is done when generic resources are unavailable. And then in the bigger picture in the communities, the regional centers help develop resources in order to vendor them whenever possible, so that we, vendoring means having a contract. The regional center has a contract with that service provider for specific services. We would then provide monitoring and oversight of those services and provide community education and outreach. And that's part of my job at the regional center. Next slide, please. So as I mentioned, we provide service coordination and develop that individual program plan with the individual and their planning team. So the family members, the service coordinator from the regional center, and other professionals who are involved in that person's life are the planning team. They look at the needs of the person and come up with goals and objectives and look at what sources there are to meet those needs. So we have to look at generic resources first. That is our obligation. So we explore those. If those are exhausted, then the service providers who are vendored with the regional center may be identified to meet the needs, and we can then fund those services. Some of our more common services include family respite, adult day programs, employment supports, residential services, and transportation, among quite a few others. Next slide, please. So San Andreas Regional Center serves about 18,000 people with intellectual and developmental disabilities of all ages, as Dr. Ezra Liu mentioned earlier. We cover 4 counties. Those are Santa Clara, Santa Cruz, Monterey, and San Benito. We work with community partners to support individuals to access generic resources and other specialists for dementia care. And basically that's what we have as our community partners, those generic resources for dementia. We're working to build our internal resources through education and information, and we're looking to broaden and elevate education outside our regional center for the benefit of the people we serve. And that's what we're doing today here. So glad to be here. The importance of education, information, building partnerships, as I mentioned. Internally, we provide training to our service coordinators, not only in their first orientation period, but on an intermittent basis ongoing. And then one of the jobs I do is to provide educational classes to our service providers, health-related topics, including dementia. I've actually got the dementia class scheduled for tomorrow, and I'll have about 20 care providers attending. We also reach out to our healthcare providers of different levels. These are usually through individual cases who may be hospitalized or in a skilled nursing facility, subacute facility, or be receiving their care through a federally qualified health clinic. Our basic contacts are through the social workers and the case managers, but also through physicians and palliative care teams in those different settings. We also have interaction with other agencies, such as Medi-Cal managed care plans locally, social services, local law enforcement, our county association on aging. We have a local agency, Parents Helping Parents, which is an organization that really provides great support and education to families of people with intellectual and developmental disabilities. Next slide. So in the trainings that I do for our care providers, one of the things that I really emphasize is the importance of them knowing the baseline condition of the individuals they serve, knowing about that person's personality, their activity level, their ways of communicating, and all of that, so that they can observe for changes, and that those changes can be reported, documented, and followed up on. So the early identification of observed changes allows for a correct diagnosis to be made by the appropriate professional, whether that is dementia or whether that is some other health condition. In the class, we define some of the key terms, such as what is dementia, what is a developmental disability, intellectual disability, what is mild cognitive impairment, and we talk about normal aging and how that compares. Talk about different types and stages of dementia, what are the signs that they would be looking for, how do we help get a good diagnosis, and how do we talk about treatment, what can be done, and then providing care through the different stages of dementia. Next slide. We have a tool now to look at decline in people with intellectual and developmental disabilities. Very grateful to have this. Dr. Ezra Liu was crucial in the development of this tool with the National Task Group on Intellectual Disabilities and Dementia Practices, the NTG. Their website is at the bottom of the page. This is a 4-page document that is easy to fill out by someone who knows the individual, and it just has different sections for their activities of daily living, behavioral changes, health conditions, etc., and can be a really great tool to document a baseline condition at age 40 for people with Down syndrome, and then it's recommended to start at age 50 for those people with ID, DD that don't have Down syndrome, and to be done every year as an ongoing way of documenting any changes, which can help in getting a good diagnosis. Next slide. So we really have to go with person-centered planning. We work through, like I said, the individual planning team, and that allows us to tailor care to meet the needs of the individual. The individual with with dementia, we need to enter their reality. because their reality changes as time goes on, their needs and abilities change. We can't always predict it. So it requires us to be educated and trained and flexible and creative in our approach. Next slide. So I try to provide other resources for information and education of our care providers and families as best I can. Here are some of the main resources that are available. Next slide, please. I just want to thank you for this opportunity to advocate for this often overlooked segment of the population in California. Your time and attention is appreciated, and your efforts for inclusion. Thank you.
Thanks so much to the Developmental Disability Services team, both Dr. Esra Liu and Lisa Run. Your sort of knowledge of and ability to explain it to people who may be less familiar about the services and supports that are available is really, really welcome. And I'm sure we'll have a lively discussion after our next two presenters. And the next one is Todd Shetter, who, as we mentioned, is part of the Active Care Living Residential Memory Care Program, and Kimberly Keene, who's the Director of Program Development at Noah Homes. So with that, I'm going to turn it over to both of you to learn about the services you provide and how those models are developing. Thanks so much for being with us.
Great. Thanks, Catherine. Appreciate being here and appreciate the opportunity to be able to introduce everybody to probably what's a new concept for most folks on the call and on the Zoom meeting today. What we're going to introduce is a new model of residential living for those folks with intellectual and developmental disabilities and dementia. But we also want to introduce the collaboration and partnership that we have been able to form and put together over the last year and a half with Noah's Homes, which may be familiar to a lot of people on this call, and the name Molly Nocon, who has served as a panelist for 3 years on the Alzheimer's Advisory Committee. Next slide, please. So we started down this road really more than a year ago in July of 2021, kind of coming out of the pandemic and kind of looking at what the world is going to look like. Molly and I have crossed paths many times over the last 8 or 10 years, sitting on county committees. There's an Alzheimer's project that was developed here in San Diego County. We have been to Alzheimer's events together. We have certainly sat on the advisory committee together. And we started talking about the environment and some of the challenges that we were each seeing in our prospective communities and kind of our fields of delivering residential care. And Molly shared some of the advancements and some of the exciting news that Noah's Home had achieved over the last 5 years with being able to build and operate 2 dedicated dementia homes. But the problem they were looking at was kind of the needs that were still out in the community that were unmet. And so that kind of led to more discussions, and we started down the pathway of looking at the environment that we had created at Active Care, and really started sharing the similarities and the needs of our clientele, a traditional geriatric population that had some form of dementia. So Active Care Living owns and operates 8 different standalone communities in Southern California. 4 are in San Diego County, 4 are in Orange County. Everyone that lives in an Active Care community has some form of dementia. And so we are used to providing a certain level of support, providing needs and helping assist folks that have a dementia diagnosis. Next slide, please. So let us kind of introduce each individual group. A little bit of a background history on Active Care Living. We have been in business for more than 30 years. And really our goal is to create an environment where we're bringing fulfillment and enhancing the lives of folks that have dementia on a daily basis. We know and understand from operating skilled nursing facilities back in the 70s and 80s that there was kind of a missing link. There was a hole in the care continuum for folks that have Alzheimer's disease. and really other forms of dementia. A skilled nursing facility is all about rehab. Somebody comes in with a fractured hip, with some kind of a condition, and the goal is to get them better and return them to their previous level of care. An assisted living community or an independent living community is dealing with aging individuals that have supportive needs, need medication assistance. They may be frail, they need supportive meals and housekeeping, but they don't have dementia. And so when somebody has dementia, we know that it's a progressive degenerative disease, and assisted living didn't provide enough support. Skilled nursing provided too much support, and really not a way to be able to meet the unique needs of folks that have dementia. And so we created a new level of care. We'll talk about that a little bit later as to how we came to that conclusion and what we did at the state level. But our goal is to build from the ground up communities that meet the needs, individual and unique needs of folks that have some form of dementia, and provide them the opportunity to live at the highest possible level of functioning for as long as they can throughout the course of their life. So I'll let Kim kind of describe the Noah's Home culture.
Good morning. And for those of you who might not know Noah Homes, we are a residential care community in San Diego County that supports 90 adults with intellectual and developmental disabilities across 10 homes. And we've been supporting this population for over 40 years. And as our population, specifically our population with Down syndrome, began to age, our residents faced the possibility of being forced to move to one of the skilled nursing type facilities that Todd was speaking about, because the level of care that they required exceeded the level of care that we were licensed to provide. And this was devastating to our residents that had lived with us for a very long time. And they were going to be forced to move away from their home and their friends and staff who had loved and cared for them for many, many years. So Noah Homes embarked on a journey to open the first memory care homes in the state of California. In January 2017, we opened our first 2 homes specifically designed to care for this population. And since we opened those homes, we've served 37 residents, most of which had a primary diagnosis of Down syndrome. 17 of those residents had the opportunity to pass peacefully in their longtime homes with friends, family, and staff that had loved and cared for them for many years. We currently have over 200 people on our interested in placement list, many of which have a primary diagnosis of Down syndrome, and their families understand that their loved ones will likely require memory care homes either now or in the future. Sadly, because we have so many residents who we expect that already live here that will need those homes, we don't see any time in the foreseeable future having an opening for any new residents to move. So we joined forces with Active Care Living to share our best practices in our successful memory care home program design. Next slide, please.
So real quickly, I know that we've got limited time and we really want to get into the moving pictures and show you some of these environments. Active Care was able to work with the Department of Social Services back in the late 80s, leading into 1995, where new legislation was created to provide really a dementia waiver program that turned into a way for communities licensed as RCFEs to provide appropriate care in a residential setting under an assisted living licensure. And so we had the first in California residential community that was licensed under an assisted living program as an RCFE, specializing in memory care. And that kind of led us down the path to where we are today. Next slide, please. So once we kind of learned of that great need, as Kim described, we gathered forces and put together applications and submitted vendorization packages to the San Diego Regional Center with the idea of creating a pilot project in 2 of our San Diego County communities, one in Active Care at Rolling Hills Ranch in Chula Vista, the other one at Active Care 4S Ranch, which is located in central San Diego near Rancho Bernardo. We were granted that vendorization for 20 accommodation in each one of those communities, so a total of 40 living opportunities for folks that have intellectual and developmental disabilities and dementia. And so we started down that road earlier this year, and we're continuing to work with the regional center doing education to spread the word that this opportunity now exists.
Next slide. Noah Homes toured Active Care over 3 years ago, and we were really impressed with what we saw. It's a beautiful, inclusive community. Dedicated caregivers encourage the residents to engage in activities and programs that help stimulate their cognitive functioning, increase self-confidence, and it's very much like what we see here at Noah Homes. Several months ago, we began to bring our residents for activities, and they have a great time exploring the community. It was really heartwarming to see how welcoming everybody was and the fast friendships that were formed through shared interests. Next slide, please. So here's a quick tour of Active Care Rolling Hills Ranch. If you could play that video for us. Thank you. Next slide, please. Here's a few photos of the Noah Homes residents visiting their friends at Active Care. They look forward to going back and visiting and participating in the robust day program activities that they have at each of their locations. Next slide, please. So what's happening with our partnership now? Our first residents moved into Active Care Forest Ranch on August 1st, and our second into Active Care, Rolling Hills Ranch on September 1st. We currently have 3 residents that reside in Active Care communities. And our first resident, Mark, was on our interested in placement list for several years here at Noah Homes. He was waiting for an opening in one of our memory care homes, and his family did his best to support him during that time. But it became a daily struggle as they began to age and his needs continued to increase. So next slide, and there's a quick, oh, I'm sorry, if you could click on the video of our first resident, Mark.
I think it'll be really good for Mark because he is going to have the stimulation he needs, being around other people, and he'll be a lot happier because he had the stimulation of going around talking to the neighbors, and he had his little thing going on with my mom, and then my mom passed, and it was pretty traumatic for him. Then after COVID hit and he had to stay home, that was hard, and when he went back, I think he got in a slump because it wasn't anything new for him, and I felt we needed to do something and look for a place for him to live. And the next day, it's a miracle, the next day you called me. It'll be real nice, real happy for him. I'm trying to stay positive. It's just a vacation for him and me, and we'll still see each other, and he'll be a lot happier.
Thank you. Next slide.
All right, so what's going on now? So Terry is another resident we want to highlight real quickly. She lives at Active Care Rolling Hills Ranch. She moved to us from a skilled nursing facility out in East San Diego County. She was kind of stuck in the system, and we were able to get her to her new home, her new environment, where she really has thrived. She has gained weight. We've been able to work with the physician and go through and DC 2 or 3 of the medications that she was on for anxiety and other conditions. And she's made a new group of friends. And so she is really just embraced and lives in this environment that for her is like a daycare program that goes on 7 days a week, 24 hours a day. So she's just really in her highlighted part of her life.
Next slide, please. So the residents.
I'm sorry, after we see this video or after we talk about this, you're at time. So if you could kind of wrap it up, that would be great because we have one more presenter and then some discussion. Thanks so much.
I'll take a quick minute. So the residents who've moved into the active care communities are thriving physically and socially. They're individuals who have benefited from staff who are trained specifically to work with this population. Many may still be at home with aging families who are struggling with their own age-related issues, or they could be in a level 3 home waiting for a higher level of care to become available. So like several residents that already call active care this home, they have moved from a skilled nursing facility, but many are still inappropriately placed in those facilities and would truly benefit by moving into a day program setting that is also their residence. So this model of care provides our most fragile population with the highest quality of care by highly trained care professionals in a beautiful, inclusive community environment that's filled with meaningful daily activities. Thank you.
And the last thing that I will say is we're excited to announce that a week ago, we submitted an application for vendorization to the Orange County Regional Center for 40 more beds in 2 different pilot project locations in Orange County, one of which Nancy Bargeman was able to visit and spend some time with us this summer earlier at Active Care Yorba Linda. So we appreciate your time and the opportunity to introduce this to everyone. Thank you.
Thanks for the good information. And now, but certainly certainly one of the most important presentations is just hearing about a family caregiver's experience. So Mark, please take it away. Thanks again for being here. We're grateful to have you.
No, I've been extremely impressed. So thank you for inviting me. This exceeds my expectations when Michelle asked me to be part of this group. So again, thank you. And my hat's off to all of those who presented before me. As I like to start, there are probably 3 key messages as I kind of share the journey that I've had with my brother. One is educating, and the documentation you've all presented is extremely well put together. Hopefully it can get out to those 377,000 and more people growing with Down syndrome. The other message is, of course, people having access, and as you know, access to good medical care is a challenge for all people, but depending upon where you are on the economic ladder, it can change depending upon that individual's family. And then I saw one slide that it was very important, and that was the navigating through the early days. And personally, when I see parents with a child with Down syndrome, I have a desire to talk to them and say, down the road, hopefully you're aware, but I think that would be very tasteless, but hopefully those people I see have access to resources that you've all communicated. And the last key message is we are fortunate to be in California, and I'll share about that with you and why I believe California has a great amount of resources versus other states. And many of you know about the other states better than I do, but my reference point will be Nevada. So, and I'll stay on time.
You're doing fine.
First of all, I'm from Southern California, and now I live in Northern California for the past 40 plus years. And my mother gave birth to my brother John just outside of 40 years old. And back in that time, it was challenge for women who had children after that at that age. Now things have changed since then, but that was our environment. And we had a ironic occurrence. We lived next door to a registered nurse, and she at that time, in the early days of my brother's birth, informed my parents that my brother had Downs, and it was not on his birth certificate. It was not known until she made that comment. And of course, my mother and father denied that fact until they learned early on in terms of how he was slowly developing. I have to say that while we're in Southern California, my mother and father were very, very involved with the regional centers in Southern California. As my father became much more aware, my mother became much more aware, they became, community activists in the care and advocacy of my brother. And then I moved up to Northern California in the late 70s. And in terms of philanthropy, I saw an organization called MARC, M-A-R-C. And I said, that's the kind of organization I want to be a part of. And I learned it was Marin Association for Retarded Citizens. Now, you know that name is no longer used. It just shows you how far back we've changed nomenclature and terminology to be more appropriate, but that was the organization. And fortunately, I was on the board and became very involved with the community activities because we had a high population of residents in our various homes who had Down syndrome. Over time, as your chart shows, those homes are now being have people with more autistic disability versus Down syndrome. And I didn't say my brother died at the age of 53. 53. If you think about Dr. Mobley's charts of the mean age, that mean 53. Excuse me. So he passed at 53, but before then, my parents had moved to Las Vegas, and that's why we saw a big difference of services for my brother compared to California. Fortunately, my father and mother had retired, so they were able to become activists in the Las Vegas community also. And my brother became, had a work environment, as you had indicated. Many Down syndrome people can carry a normal, if you will, Down syndrome life without a lot of complications. And then as your video showed, my brother did have a traumatic event. My father died, and slowly, not immediately, we start to see cognitive impairment to the point where he became from a mild-mannered John to a very aggressive. And in Las Vegas, we really didn't have a knowledge about what was the real cause. My brother had a psychiatrist. The psychiatrist provided an abundance of medications, but we didn't have any training, if you will, or education on how to deal with it over a period of time. Since my brother lived in Las Vegas with my parents, and I lived in Northern California, I fortunately had the resources to fly back and forth, seeing the psychiatrist and my mother to help move it along. But again, we were really not that knowledgeable. And I fortunately had a friend who was a psychiatrist. I said, what should I do about John? And he gave me the truth. He had zero bedside manner. He said, Mark, your brother's not going to get any better. And that was a big shock. Because again, I didn't know. My parents didn't know. My close friends didn't know. Secondly, I have a nephew who is becoming a doctor. And then he shared the UK study about the correlation of Down syndrome and Alzheimer's. And that was a welcome, because now I knew that there was some correlation and what I should expect over time. So then we got aggressive in terms of, I should say, not assertive. Took my brother to UC Irvine to get tested at their facility there. They had a wealth of doctors there to help us understand. Unfortunately, John did not like needles, and so they were not able to get any blood tests. And ironically, since that day on, he was rejecting a lot of things we wanted to do because we broke the trust factor. And many of the doctors says, well, your brother has, obsessive impulse syndrome. And again, that was not a very good diagnosis as far as we're concerned. And in the later days, I would say maybe the one negative positive is that when we did find out the Alzheimer's, he had a very rapid decline. And we know those of, since I'm a vice chair of the board, on the board of the Alzheimer's Association in Northern California and Northern Nevada, we see a lot of people live with the disease for many, many years. John did not have that. He went rapidly from a group home where he was violent with the caregivers. Even he attacked me. And then 30 seconds later, he would say, I'm sorry, he'd go back to normal. So he showed substantial behavioral challenges along the way. We had to hospitalize him. And shortly thereafter, we had to put him in hospice. He was in hospice for about 3 weeks, and then he passed away. I could go on and on and on. That's not the purpose here. I would say that every presentation that has preceded me today is indicative of what we experienced. And so that's what I'd like to leave you all with. I'm, again, very impressed with the body of work. I hope that there can be outreach, because the resources that you all have provided today were not at our grasp, 20 years ago. Frankly, not even 10 years ago in the Nevada area. So I want to stay on time, of course, but I just wanted to be able to share that brief experience. And as you can see, these pictures that you have on the screen go far back. I now have a great beard, and my family is much older, but thank you, Michelle, for sharing that with the audience here. Back to you.
Thanks so much for your presentation and for being such a great advocate for your brother. I think we always learn from family members' experience about what worked and what didn't work, and kind of how to move forward. So thank you so much to you and all the other panel members. So we're going to take about 10 minutes to just among the panel members to have a discussion about sort of lessons learned and what are future needs of in this topic area. So I welcome any comments from panel members, and then we're going to open it up to a full committee discussion, and then followed by public member comments. So Barbara, go ahead.
In the Alzheimer's space, in the last couple of years, we have really raised focus about healthy brain, all the activities you can do to reduce risk. So I'm curious if you feel, maybe this is to Dr. Mobley, but any of you, if you feel that that same messaging is applicable to this community as well, and if it is, if that's something that there needs to be more of an effort to get out to that community, to educate people on.
Yeah, thanks, Barbara. I'll start. The same risk factors that are active in the neurotypicals have relevance to the Down syndrome population. Think about what those are. Reduced education, that's a very big risk. We got that. Difficulties with hearing, we got that. And I think problems with mood disorders, check that box. And then I think particularly relevant to what Mark just spoke about, there's a very real need for social contact. The ability to be in touch with other folks, to have warm and happy relationships is extremely important for all of us, but it really is important in people with Down syndrome. And Mark was relaying a story, when we see people in clinic and there are new problems with memory or behavior, we try to take a very careful history about what's happened socially. Has there been some change in the family? Has a family member died? Has a friend moved away? Has the person been bullied? Have they been physically abused? People with Down syndrome have this incredible memory. It's like a photographic memory. It's probably not the right word for that, but they tend to remember things and events with extreme detail attached to them. And you could say, well, that's a positive thing. Yes, it's positive, except that they ruminate on that. So if they have a happy experience, they may ruminate on that. But if they have a negative experience, they may ruminate on that. And that may, in fact, be severe enough, troubling enough, that it puts them into a depressive state. And now, for all the world, they look like somebody who may be having problems with memory. So I would argue that all that 39% risk of modifiable factors attached to the emergence of AD in typicals applies to Down syndrome as well, and a special emphasis on hearing, vision, and social interaction, and paying attention to sources that could cause depression.
So thanks for that. And I think, Barbara, to your question, it's also that how do we share that information across systems, right? And promote sort of the healthy brain reduction of risk factors, right? So thanks for that. And Dr. Esrelou.
Yeah, so the Healthy Brain Initiative absolutely does apply to individuals with or without Down syndrome or IDD. So, as Dr. Mobley was saying, those modifiable risk factors. So attention to nutrition, attention to physical activity, attention to sleep issues, which are very big within the population, stress reduction, social connection, and then really kind of, and I may be missing one of the pillars, but in any case, being able to pursue if a person has a chronic physical issue already, chronic condition, the earlier and more aggressive, like diabetes or any kind of chronic condition that can set the person up for higher risk for Alzheimer's or related disorder. I mean, individuals with Down syndrome certainly have high degree of cardiovascular risk, and we do see people who have Alzheimer's and or multi-infarct dementia, cerebral vascular dementia combined because of those risk factors. So, and getting things out, I mean, my hope is that the Alzheimer's, Association will partner with DDS, that DDS will partner with the Department of Aging and look at the Alzheimer's initiative, particularly for this population, and disseminate this information through the regional centers, which is where I think they will reach families that are Lanterman eligible and who need this information.
Thanks so much. Mark, I guess my question to you is just looking at future needs. You talked a bit about, California being different than other places. Do you have a sense of you have any recommendations for California about things that we could do? I think you're on mute too. My most common error with Zoom.
Okay, no. Thank you. I heard the question, Catherine. Thank you. I was trying to communicate the contrast about the resources that exist in California versus Nevada. Stark difference. California is in my experience, much more advanced. I saw my parents becoming, as I said before, huge advocates for my brother and others in the community, where there was not a comparable regional center, for example. All right. So, and my family and I were very involved in regional centers from, an advocacy point of view. So that's what I meant, Catherine. Hope that makes sense. So the only recommendation is, how do you get the message out there to people who need it? That's probably the biggest comment I can make for you.
Thank you so much. And I think there's real wisdom in that. And I know something that both CDA and the Department of Developmental Services are interested in, about that collaboration, about sharing information from both systems. So thanks for that.
Sure.
So do other panel members have questions or comments?
I'd like to answer something that came from Kristen Rains in the Q&A. It was about the coordinated family support services. So I was about to type out the answer. So I appreciate the opportunity to just verbalize it. And that is, although the CFSS is not dementia or, aging and Down syndrome specific, it is meant to be a program that will help aging families and individuals with Down syndrome and dementia, so that the workers, the CFSS workers, will have exposure to resources that are relevant and help the families navigate, getting those resources. At least that's, the vision for this. And I think it will be very helpful, because as we've heard from other speakers, this will be it'll be necessary to hear about how to navigate multiple systems so that we're not siloed, and we actually can pull in the resources from Department of Aging and from other public health, from other entities that are offering relevant services for individuals served through regional centers.
So thanks very much. And I really appreciate the let's move away from silos and figure out how we learn from each other as a strategy. So that's great to hear. And we have a comment from Lisa Rund and then Dr. Mobley. And I want to open it up also at this point to other advisory committee members. If you have questions or comments, please feel free to raise your hand. And we'd love to hear from you too. But Lisa.
Thank you. Yes, I just wanted to take this opportunity to agree with a comment Dr. Mobley made about the need to create a more robust clinical care network. Totally agree with that. And in addition, the need to create a more robust community care and community services network. I feel like I'm such a small voice in this big arena of trying to share the information, share the knowledge, and the more that we can have interagency collaboration and cooperation with getting information out and building these resources, the better we can do. Of course, that takes funding. That's always, part of it, but I would just advocate very strongly for that. Thank you.
Yeah, thanks for that. I think one of the things I was struck with, both in the planning of this and in the presentations, is there is a robust developing sort of system change in Southern California. It seems San Diego and Orange County, and maybe less in other parts of the state, which in part just reflects how big California is. But some really emerging ideas of clinical treatment and service delivery. And so I think it's something like, how do we advance that in other parts of the state and build upon that and look for other, interesting and effective models of care. So with that, Dr. Mobley.
Yeah, just thanks to Lisa. I, of course, really second what you're suggesting, what you're speaking to. When I speak with families, I ask questions about, so how, actually, this is after the NDSC meeting. I said, so how many folks in the room have care from somebody who has really any expertise with Down syndrome? And in the room of 50 people, 2 hands went up. So whatever we're doing right now, and I agree, California is light years ahead of most places, but whatever we're doing right now is not enough. And it's not enough at the level of the training, getting the message out, getting people ready to see these patients, providing clinics that call out expertise in Down syndrome. It's a problem for children, but it's much less of a problem for children than for adults. And so what we see is that adults with Down syndrome who, I've had 30-year-olds come to clinic, and because there's been some social event that causes them to be depressed, they're diagnosed by a neurologist, mind you, at age 30 with Alzheimer's disease, which is ridiculous. It's completely, there wouldn't be one person in a million with Down syndrome that has Alzheimer's disease at age 30. But here's the family bearing the burden of a misdiagnosis, of a lack of an opportunity to care for a depressive condition in a thoughtful way. So there's suffering out there that can be avoided. And I just think if this committee could come together and find a new way of thinking about caring for adults with Down syndrome, I think it would be wonderful. And maybe it would be nation leading, because quite frankly, this is occurring across the country.
Hey, thanks so much for that. I wanted to see if any other members of the advisory committee had a question or a comment about sort of needs, ideas for future thinking. So Andrea, please go ahead.
Hi, this question is for Mark. I really enjoyed your story, your personal story in regards to your brother. One of the questions I asked, only because I worked in these facilities as a direct staff, and I'm just curious to know how the structure was for your brother and how the direct staff was for your brother, and what was helpful or what could have been improved.
Number one, the interaction was good. And I felt that there was probably at least 2 camps. As you know, being an advocate in if you're in the regional center, you can see the parents who are active, who want to help and also want to receive. And then there's other faction that are just want to receive. And so I think I felt that we had good engagement with the regional centers. My father and mother had the capacity to interact with them. And so we had a good experience. Let me say that. Was it perfect? No, but it was, people were receptive. They saw my parents were giving in terms of their time. And so, Andrea, the answer is we had good treatment. What could have improved? It's all about resources. No governmental resource has unlimited. So we had to pace ourselves and what to expect and go to other sources to help. Other sources mean other family members, understanding. So that's my answer. If I could just say something here, what helps is the education side, and Dr. Mobley said it and other panelists too, but how do you help people go through that journey over time and communicate? So I hope that's helpful, Andrea. It is about that care. You know, when someone looks at Andrea in the eyes and they can see that she cares, that goes a long way than just being another number, because the family is stressed anyway. And so they don't need to have someone who is, you know, I know that it's not a difficult job. I know it's not difficult. It's difficult, but still the family is in need. All right. Sorry for the elongated answer, but hope that's helpful.
Thanks so much, Mark. We have 2 other comments from advisory committee members, or maybe only one now, maybe 2. Okay, we're going to let Dr. Farias go first.
Hi, thank you. So I see that I had, or there was a question about the CADCs and their role. And I actually, sadly, kind of had the same question because, you know, we get very few referrals for evaluation at our Alzheimer's Disease Center in Sacramento at UC Davis. I can't speak to the other centers, but I imagine it's probably quite similar. So I guess I have a question for the panel about why you think that might be, and also, I guess, how we could be more involved and more helpful.
People have any comment about that?
Yeah, you know, so I have a couple of ideas about that. One is that, you know, who are the people who would normally refer individuals for a workup at your center? I think most families are going to go to their family physician. You know, their PCP is the first stop, and it may end there. So if the PCP does not have a sense that this might be operative, they would have no reason to refer the family on to a further workup. And I think the other piece is that a lot of families do not know about the resources for whom it might be relevant, do not know about the resource at your center where there might, if they had concerns and thought that this might be indicative of brain changes, they would go directly to you. So it's getting the word out about your resource, but also educating the medical community about being able to refer out appropriately when it's not any kind of routine thing that a PCP would normally be handling.
I think the other strategy I might have, and then we'll go to Todd, is, you know, because the regional centers are such a resource for families who have questions about what's happening to a loved one, I think trying to find ways to make connections between your centers and the similar ones and the regional centers that serve that same area would be really helpful as a way of then the regional centers can become a referring entity potentially to the center if it looks like something like that is indicated. So it might be good to like figure out after this call how we can help facilitate those kinds of connections through the regional center, and I'll send you at least my ideas about how we might do that through an introduction or something.
Great.
Okay, we're going to take Todd's question, and then because I want to make sure we open it up, there's at least one hand raised by an attendee, and we promised to have a public comment period. So Todd, if you could make your comment, and then we'll go to the attendees.
Yeah, just real quickly, it's a question for Dr. Mobley. One of the things that we've seen initially from clients coming to seek services from our program is challenges that the families have had with aging parents. So can you talk about that correlation between aging parents and Down syndrome?
Yeah, Todd.
What the prevalence?
Oh, it's quite common. We're seeing, so our clinic sees any adult with Down syndrome, but those that are coming with concerns about memory loss or mood changes are like mid 40s, typically 50s, a little bit older. Now, their parents, of course, are, 20 to 30 or even 40 years older than that. So when we see them in clinic, we're hearing about parents. Sometimes the parents are there. That's great. Many times we're seeing them with siblings or other caregivers in residential facilities. And it's absolutely true that the inability of the elderly parent to care for what is now an elderly son or daughter contributes to the confusion and the social stressors. So we're seeing that, we're feeling that, and it just adds to the woes. I was going to mention something very briefly to Dr. Farias' question. There is a lack of understanding even among the Down syndrome families about what Alzheimer's disease looks like, how it presents, what are the issues that arise. And there's another thing that happens, and it just is just a reality. If someone with Down syndrome has a problem, it's just due to Down syndrome. I mean, there's this overshadowing. Well, they have Down, they're having indigestion. Well, they have Down syndrome. They're having trouble sleeping. Well, they have Down syndrome. And when every question is answered, they have Down syndrome, and there's not a careful medical analysis of the underlying question and its meaning and a proper diagnostic workup, well, that's a reason that people don't show up at skilled facilities, because after all, they just have Down syndrome.
Okay, thanks for that. Michelle, can you facilitate letting Janet Van Zoren ask a question? And then I know Celine also had a comment, and we'll go back to that after we hear from Janet, who's had her hand raised for a bit.
Yep, I think Maria or Nancy are going to open her up.
Oh, sorry. Okay, if that happened, then.
That's okay. Yeah, I'm gonna just really quickly transition us by removing some spotlights. And I want to invite our attendees today to join the public comment period. There's quite a bit of activity in the Q&A, and certainly happy to read through some of those questions, but invite you all to also open that tab and just take a look as our panelists have been responding throughout this time. If you're joining us by webinar, feel free to use that Q&A to submit your public comment, or you can use that raise hand feature and we'll unmute your line, and Janet will get right to you in a second. If you're joining us by phone, you'll want to press *9 on your dial pad, and that will allow you to join the queue. So let's turn it over to Janet. Janet, I've opened your line, but you will need to unmute yourself before you jump in.
Hello, can you hear me?
Yes.
Hi, I first want to just thank the presenters today. I think there's been an excellent coverage of the issues. And it's, thank you, Dr. Mobley, for bringing this to the forefront. I have a couple of things to say. First of all, your comment about diagnosis is so very true. I was trying to get diagnosis for a problem that my daughter was having a number of years ago. And we took her to over 20 specialists, and her problem actually occurred over a 20-year period. And she was finally diagnosed at Stanford in the neurology department as having Down syndrome and leukemia, neither of which she had. And I kept saying, what makes you think that she has Down syndrome? What is your criteria? And they said, that she has Alzheimer's, and they would say, because she has Down syndrome. And ultimately, she was diagnosed, and it turned out that she had not Alzheimer's, but Addison's disease, which also causes dementia, but is curable. I mean, the disease is not curable, but some of the dementia is curable through appropriate medications. Secondly, I wanted to say that our experience in Northern California has been so different than what has been described. We have not found that we have had success in working with our regional center to develop dementia care services or to develop homes such as the homes that NOAA has in Southern California. We visited that home. We have a committee here that's been working with at least 2 regional centers and sometimes several more than that. We've been trying to develop dementia care services and also some type of homes where people that are aging with Down syndrome and dementia could live in Northern California, all without success so far. So my question is, where exactly are the barriers? Where is the right door? Where are the services that are going to be coordinated if you live in Northern California? Thank you.
Thanks for the comment, Janet. Is anyone else on? There's lots of good comments, as Michelle and Mariah noted on the chat. So we'll see if anyone else has a comment they want to make verbally.
Great, and I'm not seeing any hands up, but I don't know, Catherine, do we want to spend some time just reading some of the comments that have been submitted through Q&A? We probably won't have time to go through and answer them, so I invite panelists who are with us, if you want to pop into that Q&A tab and provide a written response, that would be helpful. Celine, I see you've got your hand up, so
Yep, let's go back to Celine.
Okay.
Thanks everybody for a great presentation. We I think I've mentioned before, had the grant through administration of community living where we were focusing on the IDD population, and these presentations today give me a lot of food for thought, and especially Janet, your comments just now, because as an Alzheimer Daycare Resource Center, it wasn't a specialization, and we had to kind of, we built our muscles in that area. So we did a training with UCI. Then we trained our regional center on dementia. They were very receptive to it, but I do think that regional center community-based organization partnership, and I'm hoping with the CalCompass grants that we'll be able to really focus on strategies around outreach. I'm just thinking now about us as an Alzheimer Daycare Resource Center, how families would even know that we specialize in this population. And so having conversations about best ways to reach the caregivers. I think it's a unique niche, and it just makes me think about all the things, the next things we need to do as an Alzheimer Daycare Resource Center to do better care, because we are doing the care coordination. And what we did in our community, and we're small enough to do it, is we decided to use the NTG screening tool. We did a community training for all the day programs, because what we're finding as people have more medical complications and they're transferring to us as an Alzheimer Daycare Resource Center adult day healthcare program. And so all of us having, to Dr. Mobley's comments, all of us using the same screening tools so that we can talk the same language in terms of baseline, that's the approach that we're trying to do here in Napa County. So thank you for this great conversation today.
Thanks for that comment, Celine. Really appreciate it. We are at time. I want to give a big shout out to our presenters. I thought this was just a terrific discussion, both for the information sharing and the different disciplines that were involved, the different models that are available. And I think a discussion that really helps us think about what can some next steps be that are sort of that cross-fertilization and cross-sharing of information that will help address some of the barriers that people have experienced accessing services, and to help sort of promote good practices with dementia care across different departments and eliminate some silos. So really, thank you for that. I wanted to just acknowledge that both Meg Barron and Dr. Thompson have joined us, and I neglected to acknowledge Darcy Delgado, who's here from agency as a representative from Health and Human Services Agency. So welcome to all of you. We're taking a 30-minute break for lunch and stretching and whatever else people need to do. So thank you, Michelle, for building that into the agenda. So we will be back, I think it is at 12:20 to start with a whole bunch of interesting presentations from people at Aging and other departments. So I look forward to seeing you at 12:20. Thanks to all of our presenters again. So see you at 12:20. Hey, welcome back, everyone. So it's such a prompt group. Susan, I think we're ready for your presentation. Thank you so much.
Sure, you changed your background on us, Catherine.
I did. Now I'm doing childcare in addition to doing this meeting.
Well, welcome back, everybody. And I really want to commend Catherine, Michelle, and all of the panelists. That was an incredibly moving morning session. And I'm just thinking of people who've gone before us. In particular, I'm thinking of Sharon Trocki Miller, who served on this committee for many years and cared for her sister Robin until the end of her life. Molly Nocon, of course, and many people who have filled the slot, so to speak. And that just speaks to how progressive California is that one, we have an Alzheimer's advisory committee that's been standing since the 1980s, and that we have always included at least one member on this committee who represents the developmental disability community. So thank you for all the work that went into this morning's panel. I learned a great deal. And now we can move to, thank you for moving to the slide. We're going to have as a standing, I'm switching around. There we go. As a standing agenda topic, we just always want to keep at the forefront the 10 recommendations in the governor's Alzheimer's Prevention and Preparedness Task Force. And between Lauren Grove and myself, we're going to provide, I think we're going to touch on all 10 of these items between the Department of Aging and the Department of Public Health's updates and presentations. So this is just a refresher to the group of the 10 action items, all of which were incorporated into the state's master plan for aging. So they all live on through the master plan for aging. And we'll go ahead and move to the next slide. So I was going to start out with what's happening at the California Department of Aging. We were, along with other state departments and agencies and our federal partners and community-based organizations, there was a lot of activity and recognition throughout the month of November for National Alzheimer's Disease Awareness Month and Family Caregiving Month. Governor Newsom issued a recognition, a proclamation, and we'll share that with you in the chat if you did not see that already. And the Department of Aging hosted a family caregiver webinar that was exceptional. We brought in our federal partners from the Administration on Community Living. I don't recall if this happened before or after the last time this group met, but the National Strategy for Family Caregiving was released by the Biden administration, and California is committed to analyzing that work and looking for areas. We do quite a bit of what's contained in that report, and there are things we're not yet doing. So we're in that process right now of assessing where we are as a state, and we really want to seize on that federal opportunity to be part of the national caregiving strategy. Also, since we last met, the Department of Aging has received, or around the time we met, it's not clear, we received 2 federal grants from the Administration on Community Living. The first continues more than a decade of work in Alzheimer's, and this time the focus is on connecting individuals with Alzheimer's and their families upon diagnosis. So this is intended to build off of the dementia care aware. If we increase screening and detection and diagnosis, we want people to have a place to go right away. So we are partnering with that grant with Imperial County, Ventura County, and Marin County with our Aging and Disability Resource Connections and our area agencies on aging. And the model is built around the UC San Francisco care ecosystem design, and it relies upon community health workers because that is a focus of the administration in California now. Reimburses community health work. Medi-Cal will now reimburse community health workers. And we have a statewide community health worker certification program under development by HCI, the Office of Healthcare Accountability and Information. So that was the first one. It is a 3-year Alzheimer's grant. The second grant that we received was focused on the state's no wrong door system. And it allows us to establish a statewide governance council. What you heard this morning is exactly what we want to achieve, where we're breaking down silos and we're working across agencies and across departments to make the most sense and streamline programs, services, and information for the end users, whether it's older adults, people with disabilities, family caregivers, healthcare providers, community-based organizations. So that allows us to build out formally the no wrong door system at the executive level. The next is we launched our Cal Compass Awards. You will hear from Michelle Johnston about that in just a moment. We're very excited by the interest in the renewal of the Alzheimer's Daycare Resource Center model and funding for 7 sites, I believe. Michelle will give you all of the particulars. We also have launched the Cal Grows. This is the Cal Grows Innovation Fund. This is the home and community-based services spending for the non-in-home supportive services workforce. So this would be home care workers, people who work in residential care settings, individuals who work in adult day health care, adult daycare, multi-purpose senior services programs, PACE sites, as well as family caregivers. This application period closed on Friday, and I believe we have over 140 applications received. So we're very excited to dig into that and make those decisions and get that funding out early in 2023. And then another issue that this committee has closely followed for many, many years is older adult behavioral health. We're thrilled to report that in November, the Mental Health Services Oversight and Accountability Commission for the state, they approached us in the summer. They wanted to do more for older adults, and at their November meeting, they approved $20 million to support 2 older adult specific programs. One is an evidence-based program known as PEARLS. PEARLS is offered in several counties, as well as some of our area agencies on aging and some community-based organizations. And we're also lifting up a model known as AgeWise that is in San Bernardino County. And while it is not evidence-based, it's highly successful, and it's been especially impactful throughout the pandemic because it relies on telehealth. So we're building the evidence for AgeWise, and in both cases, we want to replicate PEARLS and AgeWise to more sites around the state. And why this is important to this committee is it will include, of course, people with cognitive impairments, as well as family caregivers who have mental health concerns and behavioral health challenges. And then I think there's one more. I'm looking at, okay, 2 more. The Aging and Disability Resource Connection Advisory Committee. This is a standing committee of the Department of Aging to expand the ADRC model, which is a linkage, a formal linkage between an area agency on aging and an independent living center. So we've just put out a call for applications and had a selection process, and we're going to announce next week new members of the advisory committee. And I'm very excited that I know there's at least one who has a very specialized background in Alzheimer's and dementia who will be joining. And then last, we were thrilled that we were selected by the American Society on Aging, ASA, to present at their spring conference on all of the activity happening in California with Dementia Care Aware, the Geriatric Emergency Departments, and the governor's master plan for aging, as well as the work of the Alzheimer's task force. So I think that covers everything that's happened since we met last.
Great, thank you so much, Susan.
And just as I said, we're going to roll right into Michelle, who will give you all the details on CalCompass, which
And
is
thanks for those updates, Susan. Really, so much good work happening.
Thank you. Okay, next slide, please. So Michelle Johnston, Program Director for Dementia Initiatives within the California Department of Aging, and I have the honor to work on the CalCompass pilot project. So I'm going to spend just a couple of minutes telling you a little bit more about that project. As Susan mentioned, the purpose is really to bring back a model that had been funded in the early 2000s. The funding cut later, and well, it had been funded earlier than that, but it continued on through the early 2000s, and then was cut towards the end of that decade. And really to support existing licensed adult day programs and adult day healthcare centers in being able to provide dementia capable services to help prevent or delay institutionalization and advance health equity for persons living with Alzheimer's and other dementias and their caregivers. So the total amount being awarded under CalCompass, $4.5 million has been awarded to 7 sites, and we'll talk a little bit about who they are in a minute, as well as $300,000 for an evaluation contract, and that contract is about to be signed. The amount awards per grantee were in the $350,000 to $750,000 range, and the project's sites started in November, and they'll continue. It's a very quick timeline through December of 2023. I want to acknowledge that the idea for this pilot project came from Celine, who's on our advisory committee, and Debbie Toth, and several other people who've been active in the adult day movement and providing these services and care, and have really been talking to this committee for a long time about the need, and to the Department of Aging about the need to bring back this resource and expand it throughout California. And this funding came through, it was included in the California Health and Human Services 2021 Home and Community-Based Services Spending Plan, which had been approved by the Centers for Medicare and Medicaid Services. And probably most of you all, but maybe some people aren't familiar with adult day programming and what they do. It's really community-based, so it's in a community setting. It's support for people living with Alzheimer's, and then support and respite for their caregivers. It helps keep these folks able to live at home by having some place to go during the day where they can have social connections with others, they can have activities, they can have, in some cases, depending on the program, also medical services, caregiver support and respite. And so they're just a super important service in our community, and we really want to elevate the ability to serve folks living with Alzheimer's and other dementias. The day programs were mentioned earlier. They also support individuals living with intellectual and developmental disabilities and folks with other health conditions. Next slide, please. So the goal of CalCompass is really to help elevate this model of providing dementia-capable, person-centered support for people living with Alzheimer's or other dementias and their caregivers. And as we look at the goals of CalCompass, we're really going to be working to leverage those state and local partnerships and initiatives, other things that are going on where we can tie in some of the workforce initiatives, some of the funding models, and really to create a statewide learning community from the 7 sites to look at what was done in the past in terms of the model, and then what is really current for now. To implement those best practices, to test strategies out, to build Alzheimer's and dementia capable care providers. So really looking at the entire workforce who serves these individuals, to create some uniform measures and outcome evaluation tools that can be used by other programs, and to ensure that the services meet the needs of communities who've been disproportionately impacted by dementia. And some of those communities include communities of color, the LGBTQ+ community, the community of folks with intellectual and developmental disabilities, as we learned so much about this morning, those with younger onset dementia, people in rural or more isolated communities, individuals living alone, and others. And so we'll be looking throughout CalCampus for opportunities to find sustainable revenue streams and opportunities to increase access to adult day services throughout our state. Next slide, please. So in terms of the proposals that we received, these are the types of goals that they identified for their individual programs and what they're going to be enhancing through this pilot project. So increasing the number of folks served. Some of them are enhancing their programs by adding on additional components. Some of them are doing activities focused around staff and training and workforce development. The adult day programs and adult day health centers do a lot around training and internships for social workers and therapists and other fields, physical therapy. So bringing those folks in and helping get a workforce that's competent to serve people with dementia. Activities around assessment, evaluation, and documentation, and then enhancements around caregiver education and support. Next. So we had the RFP was launched at the end of July, just before I started with the California Department of Aging. We received 27 applicants, and of those who passed the administrative and fiscal reviews, after that, those folks were scored by a panel of reviewers. And we had just a really strong set of proposals. With the $4.5 million we had allocated for this program, we were able to fund the top 7. And so this list is who our CalCampus awardees are. And as you can see, Collaborative Cares, where Celine is the director. And so we're just so fortunate to have these amazing programs, people who some of them have put their almost entire careers into this effort. And just really are running amazing programs. And so we're looking forward to forming this learning community with them to really find out what are those best practices and things we can use as we put together this model. Next slide, please. So where we're at now, our learning community has begun to meet since November 1st. We've had 3 meetings. They've shared their information with each other about what they've been doing in their programs so that they can all get to know the other programs in the CalCampus project. We've been reviewing some of the prior materials from the Alzheimer's Daycare Resource Center model. We're finalizing the contract with the outside evaluator, and then finalizing what that set of deliverables is that we're going to need to create for that new model. So come January, we'll be dividing into work groups focused on those different deliverables so that we can get everything created by the end of December. And I'm just end of December 2023. I'm just so honored to be a part of this project and get to work with such an amazing, talented, passionate group of leaders throughout our state. So thank you. And I think now I'm going to be turning it over to Tanya, who's going to talk about the Cal's Connect project.
Yes, thank you, Michelle. Hi, everyone. It's great to be here. And I'm excited to present the Cal's Connect project that we currently have taken on in 2022. It's very complementary to what Michelle just provided. And we're also looking at how to improve, the systems and quality of care as Susan described through this particular initiative. So I'm going to go into some detail on where we're at in that particular effort. So from a funding standpoint, I just want to describe this is actually a grant that we received from the Administration for Community Living. And it's the Alzheimer's Disease Program Initiative ADPI grant that is designed just for state entities. So we're very fortunate that we were one of the states that was selected for this ADPI grant. And I can tell you in meeting with the ACL, they are thrilled with this project and what we're designing and have planned for already. So we're really excited to continue in this with this opportunity. The objectives are to create and sustain a dementia-capable home and community-based service system for people with Alzheimer's disease and related disorders and their caregivers. So it's, both the individual and their caregivers using the no wrong door approach. And then assuring access to a comprehensive, sustainable set of quality services, interventions that are dementia capable, and providing innovative services to people with dementia and their caregivers. So just kind of key objectives here is, this is a system approach, improving, that integration statewide, and then also looking at, both the individual and the caregiver as mentioned. Next slide, please. All right, so project partners, we're going to pilot this with 3 specific counties, Ventura, Marin, and Imperial. Each of these agencies serve older adults and people with disabilities through a designated or developing aging and disability resource connections program. So CDA selected these sites for the strength of their existing programs and for the geographic diversity representing northern, central, Southern California, including rural communities, which we know is a big need for us to be addressing at the state level. Utilizing the ADRC programs, this approach will provide streamlined access to dementia care information and supports ensuring that those served have access to recognizable hubs that offer resources, navigation, access, assistance, and care planning. So the additional partners that will be integral to this is we'll have clinical supervision with nursing, social workers, and medication management, as well as an evaluator that's an important part of this grant program to ensure we move forward with an effective program that we can then look at the sustainable approach afterwards. So next slide, please. Now, the approach with our partners is using UCSF's evidence-based care ecosystem program, which has been extremely effective and is a fantastic model that we are thrilled to be supporting. This is an ecosystem that's basically staffed by bilingual community health workers trained as care team navigators, so CTNs. The CTNs provide specialized dementia education, work with the family to develop a plan of care, connect families with community service supports, and aid in care transitions. So not only is this, clearly creating a system and a hub opportunity, but it's connecting with these specialists who will be able to provide this level of case management and specialized support for the needs of those individuals. And then, of course, we'll be contracting with the clinical supervision to maintain that level of support beyond just, the system integration. Next slide, please. All right, so the UCSF care ecosystem model, we are very fortunate that as an evidence-based program, our evidence-based model, it is a publicly accessible model as well. And in that capacity, we are working with UCSF to make sure that this is clearly translated at the state level in a way that, honors the design and the system that they created. But it allows us to create an affordable system that can be sustained at the state level and really modeled in a way that all communities can access and benefit from, because again, it's publicly accessible. It's something that we want to be able to sustain for all to benefit from, regardless of what income levels and resources may be available from one community to the next. So that is what we are striving for when we talk about, an integrated system and launching this, for sustainability statewide. So I just wanted to share that. And next slide, please. All right, so as far as the continued approach with the pilot and consumer navigation contact center, so we are going to be promoting this healthcare system, especially with the Medi-Cal providers. So we will be looking at how to, integrate community clinics, hospitals, doctors, health plans. So, bridging the divide between medical and social services and increasing accessibility and equity among the communities hardest hit by dementia. So this isn't just, again, I want to emphasize how it's not just the system that we're standing up, the care ecosystem, it's bridging all of those resources that exist in the community. It's really bringing together these networks in a clearly, integrated, method that will benefit both the caregivers and those that are diagnosed with dementia and related disorders. So we're really thrilled to be collaborating with the State Area Agency on Aging. And we also look forward to working with caregiver resource centers as well, since those entities also provide similar resources, and we want to make sure their input is provided in the development of these program resources. Next slide, please. Okay, and just as a final note, with desired outcomes, we are working with the ACL as part of this grant project to have clearly delineated, measurable goals and outcomes to continue to support exactly what our goal is in terms of the sustainable approach to this opportunity. And so starting off with, it's very person-level, person-centered, improve the quality of life for individuals living with dementia and decrease caregiver burden. So that is a major part of what we are looking at in terms of the evaluations. System level development of dementia capacity in California's project sites and eventually throughout California's no wrong door systems. And then sustainability goals, as I've continued to mention throughout my presentation, is adopting the pilot to contact centers as an established sustainable community resource throughout California, and ensure best practices resources that will inform related statewide dementia capable no wrong door systems and programs. So we look forward to continuing this. We're in the early stages of planning at this time with ACL, with the Administration on Community Living that awarded us this grant. And we look forward to 2023 going into implementation strategy and rolling much of this out through our partners that I just described. So that is where we're at this time, and we're thrilled to be able to lead the way in the state of California with this opportunity. So thank you, Michelle, and everybody for letting me present. And I think that's it for me at this time.
So thanks to all of our CDA presenters. I really appreciate not only the information, but the focus you have on sort of reflecting the diversity of California within all of the work that's being done. It was really nice to see Imperial County mentioned. I know that's a really underserved primarily Latinx community in California. And so it's just nice to see that top of mind is that kind of diversity. So thank you for that. And I think we have actually 2 minutes if anybody else on the advisory committee wanted to ask a question or make a comment. And after that, we'll go to the presentation by the Department of Public Health.
Catherine, there was one question about CalCampus in the Q&A. I'm happy to answer.
Perfect, please.
Yes. Yeah, so Janet asked if the CalCampus programs include specialized training and expertise for caregivers of those with intellectual and developmental disabilities and dementia, who tend to be younger, have more pre-existing cognitive deficits and a different culture perhaps than other general public members with dementia. And yes, several of the sites that we selected actually are already serving individuals with intellectual and developmental disabilities who also have dementia. And that's definitely, as I mentioned, those communities that we're focused on in the equity piece of this. That's definitely one of the communities that we want to make sure that the model really serves in terms of training that's needed for staff, training for caregivers, to make sure that we're supporting folks in that community. So thank you, Janet.
Perfect. Okay, I'm not seeing any other questions or hands raised. So why don't we turn to Lauren Groves, who's going to do the next presentation?
Oh, good afternoon. Thank you all for having me. My name is Lauren Groves and I'm the Chronic Disease Control Branch Chief. And I did want to just make one big announcement before we go into our actual presentation today. I'm just going to talk to you guys a little bit about what the Department of Public Health is doing around the Alzheimer's recommendations. And I'm really excited because the team was built out in the last year and we've gotten to get most of our funding out the door or very close to out the door. So we're going to have a lot of really good updates coming your way. But before I do that, I just want to let everyone on this call know that we have hired a new Alzheimer's disease section chief for our program. Her name is Lindley Stern, and she is on this call with me today, and you will likely hear from her in the future. I'll give her a chance in a little bit to introduce herself because I just put her on the spot, but when she has a few minutes at the end, I'll let her introduce herself. But we're really excited to have her. She's been part of our team since we built out in January, and so this is a really natural progression for her, and we're really excited to have her. So next slide, please. Go to the next slide. I just want to go ahead and kind of give an update on all the work that we're doing. And I think one of the big things that isn't talked about often are California Alzheimer's disease centers. So just a quick reminder for everyone, we do have 10 of those throughout the state. And they do receive $281,000 per year per center. And we are looking at starting new contracts with them in the next year. So they are ending out a contract phase now, but we will be entering into a new contract phase in July of 2023. So we're really excited for these centers. Just so you know, their focus is really around improving the care delivery system and what we can do. But they also act as experts for us in the Department of Public Health. We meet monthly with this team and we really utilize that time to talk about what's coming next, what else we need to be looking at, what should be on our radar, what they're seeing in the actual clinical field. They also do awareness and education, both to providers and to the community. So they're just a really great partner. And they've been sort of the backbone and infrastructure of the Department of Public Health's Alzheimer's work for many decades now. So I always like to start with them and give them a little bit of credit for what they do. They've been incredibly helpful to us in this program. And so we can move on to the next slide. And then we also have our Healthy Brain Initiative, which was brought up earlier. And I want to say too, the conversation this morning was excellent. I thank everyone on the panel for being part of that conversation. I've learned so much from today already, and really bringing back those conversations into the work that we do. So for example, in December, our CADCs are going to be having that exact conversation. What can we do in Northern California to help this specific population? Is there anything that we need to be implementing in the future? And in addition to that, our California Healthy Brain Initiative next cohort that we will be funding out shortly will have an emphasis on looking at this population as well. So just want to kind of say, we hear you, we appreciate what this committee brings, and we are definitely looking at how we can incorporate that into our future work as well. So we do have our California Healthy Brain Initiative. We did have a pilot project. It ended in June of this year, so June 2022, and we were really excited in the new budget. We did receive another $10 million to continue this project. So these projects, this $10 million will fund all 6 of our pilots for another 2 years. So that includes Los Angeles, Placer, Sacramento, San Diego, Santa Clara, and Shasta. And we're working with them currently at this time to get those contracts up and running so they can restart these programs and really continue to reach out to the community and advance cognitive health as part of their public health departments. In addition to that, we will be spending a portion of this funding to start a cohort number 2 as well. So we will have a competitive RFA that gets released sometime early 2023. I'm going to say January, February timeframe. We just need our RFA to get approved, and then we can get that out in the community and try to bring on 6 or more new counties to help with the Healthy Brain Initiative moving forward. Next slide. And then to jump into the big influx of resources that we received, in large thanks to this group and the hard work that all of you do, we've been working really hard over the last 10 months to find ways to get this funding out, to be sure that we were funding the right partners. And that really started with our California research projects. Again, this is an area our team has been in for quite some time now, but we were able to really give a nice influx in the funding. So we were able to give out $8.7 million to 7 different research projects this year. And those contracts are all signed and executed and ready for their November 1st start date. So we're really excited about these projects. And then we'll move on to the next slide. We also are incredibly excited. You guys are the first group to hear this, so we're very excited. We've been through a really extensive RFP process for a public awareness campaign for $8.5 million for the next 2 years. In this campaign, we just announced, you can find it on our webpage, but we will be awarding Runyon Saltzman Inc., which is an media agency, and it just got announced last night at like 4 o'clock. So we're really excited. We were excited to be able to announce it today, and they are going to do great work for us. If you have questions about that campaign, by all means, please feel free to reach out to me or Lindley. We can help with some more in-depth information on that, but we're really excited. They won't start till March, but we have announced our award at this point. Next slide. So we also have our dementia-friendly communities, and I think some of you may know this is our long-term place-based interventions that really are intended to serve our healthy behaviors, and has been referenced, kind of periodically and throughout as our Blue Zones work. And so we are contracting for a Blue Zone county-wide pilot, and it is a $1.7 million contract. That contract is also in the final phases of signature on both ends, but we will be working with Sacramento County for this Blue Zone pilot. We are providing them this funding to begin the process, to go through the entire analysis, assessment of the community, and establish what needs to be done to build the infrastructure for really that long-term place-based intervention work, and then also begin that work. So we're really excited again to announce that that's going to be with the County of Sacramento. Next slide. And then we also have our caregiver training program. And so we're actually going to be focusing on the unpaid family caregivers with this particular program. And the big requirements for us when we looked at who to fund were that it had to be at no cost, online, and multilingual, and that it needed to include partnership with local community organizations. And so we are currently in the process of finalizing contracts with 2 universities to provide this caregiver training in both Southern California and Northern California. And what I really like about the way that this program has played out, with our 2 partners, is we're offering sort of 2 different paths for family caregivers. One is a really sort of static web page where you can go in and get training, kind of plug and play whatever you need at that moment, what's best for you at that time. You can watch it, you can go through those webinars, go through those activities at your own pace and when needed. And the other is really a cohort experience where you're still going to be doing the courses and the training online, but you're doing it with a cohort of individuals. It's an interactive presenter and attendee relationship in those. And so that's really intended for the caregivers who are looking for that additional bond, someone else to talk to, that additional social support that they need, and that have the time and ability to attend that type of training. So it's really exciting because we'll have 2 different types of training, and then both of those groups are working on making them culturally competent for the multiple different communities that we have in California. So really excited. I'm hopeful. Well, I know by the next time we all meet together, we'll be able to give the names of those 2 contracts, and they'll be well on their way to getting the work started. Next one. And then our last kind of area of funding that we have been working on is our standards of dementia care. And with this, we're excited because we've been able to refocus this particular funding group to really look at building a public health risk reduction model, but also provide some support for post-diagnosis resources for providers. What we heard loud and clear, and what we've heard when we're working with our dementia care aware partners, is that once someone is diagnosed, providers in particular on the primary care side need some help and support on how to treat that patient and all the pieces that go along with it beyond just the treatment. So what resources do they need as providers to provide good care to their patients? And so we've been looking and working on those two pieces and looking at a final contractor for that work. And then also our risk calculator. So having a way for providers to really calculate risk for individuals and really help us, diagnose those who have not been diagnosed in the past. So really excited about this work as well. Next slide. And then for this one, I just wanted to let everyone know, and I have some of my cohorts on with me that were in attendance at this as well, but the Alzheimer's Association had their first ever State Dementia Service Coordinator Summit in October, and I was lucky to attend. It was really great. It was in Washington, D.C., and a few of the key takeaways that I really got from this conference was the importance of establishing a state government response to Alzheimer's. Great about that is we have our recommendation document, we have our master plan of aging. And so we really have in that particular. The second thing that I really learned was we have to keep our eye on the future of Alzheimer's treatments and what that means for the standard of care and what that means will change for our provider groups and what they need and what we need to be able to provide to patients as well. And that kind of ties into the third piece, which was the public health approach to dementia. How can we start to shift the conversation towards healthy brain, risk reduction, prevention of this disease, and how can we really change the social norm around what Alzheimer's is? And that's a huge part of, I think, the next phase for Alzheimer's work in public health. And then just also the importance of supporting caregivers. I think everyone on this call can agree that that is embedded into everything we do in California and is such a big part of what we plan moving forward. But it was really great to hear from all the states and get these great ideas on new things for everyone. So I'm just really excited about that. And then last slide. We obviously have questions if anyone would like, but I just wanted to also mention in month, we will create a new version of our communication kit for social media. So I can put in the chat box a link to that if you're interested, but it provides you images and messaging you can use for social media. And then, as I mentioned, we do have our new Alzheimer's disease section Chief, Lindley Stern. So I'm going to turn it over to her just really quickly to introduce herself. And then if we have time, I'm happy to take questions.
Thank you, Lauren. It's nice to meet everybody today and be a part of the conversation. I've recently been serving as the research program lead with the Alzheimer's disease program. So this is a natural progression into this role. I look forward to working with you all, and I loved hearing the conversations that went on today. Thank you.
Thanks, Lindley. And then do we have time for questions? Is that okay? Or
Sure. Does anyone have a question? Anyone on the advisory committee have a question of Lauren from that very informative presentation? Thank you so much.
While we're waiting, I was going to say, while we're waiting, I just want to say, I want to give a huge, kind of shout out to the Alzheimer's disease program here at the department. The team, it was started as one person in January, and it's up to a 6-person team. And I just want to say they've worked so hard to really understand this disease, really understand what the best public health model looks like for addressing this disease in the state, and have focused really hard on getting this such important funding out to the community and in the hands of the experts. And so I just I'm so proud of them, and I'm so enthused with what they've been able to do in a year. And I think, we all know that contracting is not always the easiest process, and to be able to get all of this out the door has been a huge, kind of push in the right direction, has helped us make good progress on those recommendations Susan mentioned at the beginning of her presentation. So I just want to commend all of them. They're not all on. I've invited them in the past to be on. That we've got a lot of things today that are happening, but they've worked really hard to move this forward.
Perfect. Thank you. I know there's some questions in the chat. So what might make sense, I know Michelle was typing an answer to some of them. So if you don't mind just looking through those and seeing if there looks like the last one potentially you might want to, maybe you could speak to.
Yeah, I'm looking at them now to see which one. That might
Perfect. That'd be great.
Um,
Thank you.
So there's one question, will all of these programs specifically include expertise needed for serving the needs of those with IDD and dementia? I think that it's not necessary that all of them would specifically include that expertise. I think that that level of expertise is growing in the state. I think what we're doing is putting an emphasis on trying to increase that expertise and bringing the right people to the table with these types of programs. So I don't know if that exactly answered the question. And I don't know if it was at a subset of the presentation, but I think that one was a big one to ask. And then there is a question about, do any of the California Alzheimer's disease centers have the expertise with which to diagnose dementia in those who have pre-existing cognitive deficits? Diagnosis for them involves specialized training and tools. And I'm going to say yes, but I will have to check on which ones specifically that would be, but we can certainly get back to the group on that and let everyone know. But there are varying expertise within the 10 centers, so they all have different expertise throughout the centers, but I will check on that and get back to the group.
And it looks like there's a last question about people are interested in learning about the upcoming funding opportunities and so forth. So
yeah, so the upcoming funding opportunities, as they're available, we do post them on our website, the California Alzheimer's Disease Program, our California Department of Public Health Alzheimer's Disease Program website. I will put a link in the Q&A to that webpage so you can see any of our opportunities at any time. And also when we do release RFAs and various different funding opportunities, we'll make sure to share with this group as well so that you all can share with your partners and then also for those on the call.
Perfect. Thanks again, Lauren. Thanks so much for all the terrific information. Before we go to the scheduled meetings, Jared let me know that he is getting on a plane at 1:20, and I think we have time for a very brief high-level ledge update that we were going to try and put into the right before the public comments. So Jared, if you want to just give us some info, that'd be great. Thanks so much.
Yeah, thank you, Catherine. The flight's in an hour and a half, but gotta get to the airport. So I'm not like right at the airport.
No. I knew you had to leave at 1:20. I assumed.
Well,
Anyway.
thank you all so much for letting me present very briefly. The legislature reconvened at the beginning of this week, and we were fortunate enough to have our first sponsored bill be introduced. But I also wanted to mention that the work that we had started last year with AB 1618 by Assemblymember Aguiar Curry will continue as well. So first, our first sponsored bill, AB 21 by Assemblymember Gibson. This is a continuation of the peace officer training proposal that was in AB 2583. Very similar in statute right now, or in proposal right now. And we're going to continue to work with posts and others to fine tune that through the legislative process. Second, we will be taking a portion of AB 1618, the portion that was related to the Alzheimer's advisory committee, and be reintroducing that with Assemblymember Aguiar Curry. The bill has not yet been reintroduced. I'd imagine that on introduction, it'll look very similar to what we kind of fine-tuned through the legislative process with feedback from the advisory committee, but are looking forward to a continued conversation. So, our hope is that we'll be able to continue this conversation in particular at the next advisory committee, still seek feedback and input and fine-tune it so that it can be the best possible bill possible. And that's the end of my presentation or comment.
Thanks for doing that, Jared, and thanks for your work around the Alzheimer's Committee membership. And maybe you could just post in the chat if you have it, just sort of what the language was last year, or someone, or we can send it out later, just so we have some new members and people can kind of be aware of that. So that'd be great. We are now going to do just review our meeting schedule for next year. It's going to look somewhat different than what we have done this year. So we are meeting starting in February, May, August, and November. The meetings again will be from 10 until 2. And that helps us align with some of the things that are happening legislatively, I think, in ways that we haven't been able to do before. So the governor's budget will be out in January, and that'll provide us with the opportunity to have some information more timely about that. So that is the schedule that CDA has proposed. So any questions or comments about that? And thank you, Lisa, who is, I think, leaving us now. So perfect. We appreciated you being here. Okay, the next area we're going to talk about is, do we need to, I thought, hold on. I think we were going to do topic ideas, right, Michelle, before we switch to the recommendations? Is that right?
Yes, so if you go back one slide, please. Yeah, so at this point, we're going to talk about the.
Okay, just making sure. Thank you. So at the beginning, I had mentioned that one of the things this committee has done is have the ability to recommend topics they're interested in, so we can weave them into the agendas during the year ahead. So really want to hear from all of the members of the advisory committee. Are there other topics that you want to have discussed? And I see that Barbara has her hand raised.
I do. First, I also just wanted to say that, so my organization, Alzheimer's Los Angeles, in partnership with Alzheimer's Orange County and Alzheimer's San Diego, is also going to be introducing a couple pieces of legislation that I would love this committee to keep an eye on, and certainly would welcome support as we move forward. And just like Jared, there are going to be reintroductions of efforts from the last time. Last session was challenging, I think, for a lot of us. So one is going to be a task force, or I guess we're calling it a work group, to address the issue of wandering. So I'm sure you all know, 60% of people who are living with a dementia are going to wander at some point. And at this point, there is no coordinated way for law enforcement in different counties to communicate. There's no coordinated effort to help families know what they can do to prevent wandering. So we're hoping to convene with state DOJ an effort to address that. And then the second is, we've talked off and on today about the Dementia Care Aware program, which actually that would be kind of, I think, valuable going forward, maybe to have a presentation from them about what that is. It's fantastic work that's ongoing. We certainly hope that it leads to increased accurate, appropriate diagnosis. And so anticipating that happening, we are going to again be looking for funding to increase access to caregiver supports and education. And then there's two other, for future topics, issues that I have talked with Michelle before that I just want to raise here. One is something that we're seeing in Southern California. I don't know if this is happening in Northern California as much, but they're predatory clinics. So these are people who are proposing they can do things like cure Alzheimer's and charging a whole lot of money to do it. And so, we're talking with California Department of Aging about, what kind of messaging might go out to families, kind of like a buyer beware. But anyway, that might be something for the committee to explore. And then the other is, I know CDA is also convening a stakeholder group to look at ensuring caregiver access in nursing facilities. What we went through with the recent COVID situation. And so I would be interested in hearing what's coming out of that group. And the same issue exists in the hospital setting. So I know that work group is very narrowly tasked to focus on only particular care settings. So they're not going to be taking up hospitals, which I understand, but this is still coming up from our support group members that they don't have consistent access when their loved one has to go into a hospital.
So thanks for the ideas. And at the very beginning, when we were reminding people to think about this, we talked about a priority for last year had really been the social isolation that people experience in a whole variety of different settings. And my recollection is that Derek Lamb was going to be working on that issue, and that's been folded into some of the work that CDA is going to be starting, I think, after January. But maybe Susan can remind us, and then we could have a report as sort of that work progressed, which I think would be a nice look back. So can you at least remind us, Susan, what's happening?
Sure, yes. So we've finalized the composition of the group, and I can assure you that Derek will be included to represent this committee, and there will be others who also represent the Alzheimer's and dementia and caregiving communities. We expect announcements to go out in early January and for the first meeting to be in February.
That's wonderful. So thanks for that. And we'll look for an update at some point once the committee kind of gets going in the year. And the other topic, just to remind everyone, is that Dr. Canio had raised the question of capacity to make decisions and alternatives to decision making, how one decides if someone has the ability to make decisions or decisions with supports. And that topic, particularly in terms of the alternatives, there's a new bill that was passed at the end of the session, AB 1663, which creates in California both some conservatorship reforms, although those are narrower, and a supported decision-making option where people can enter into written agreements to have support in making their decisions so an individual can help them. So I think that topic we can loop back to this year, both in terms of the issues that Dr. Canio raised last year, as well as the new piece of legislation and the work that's happening at the state level. I think there's an agency level group that's working on some of those issues, and the State Council on Developmental Disabilities has received some technical assistance funds in that area too. So I think lots of work going on in that area that'll be interesting for us to hear about. Other people have other ideas of things we want to make sure we cover next year. Andrea.
Hello. I really enjoyed all the good work that's coming out. California has always been really good in regards to being very active in regards to providing services for folks. One of the topics I would love to see is that, and I hear a lot about it, is regarding a lot of people are qualified to receive Medicaid, and it would be a really good service because Medicaid covers custodial care that Medicare does not cover. And there's a lot of people living with, dementia, Alzheimer's, and cognitive impairment that are having a hard time applying for these services. And each year you have to reapply. The majority of the time you have to do it online. When you do your initial application for Medicaid, you can do it through a 1-800 number. But once you get on and you start receiving services, you have to reapply. Sometimes the caregivers don't have access to know how to apply for these services. Once you get a person get Medicaid, it really covers a lot of custodial care like housekeeping, laundry, meal prep that will be really helpful to the caregiver as well as the person living with cognitive impairment like myself. So I receive in-home supportive services, and it has been tremendously beneficial to me. But thank God that I can cognitively every year apply for those services. So I would love to see how somehow we can help with working or partnership with maybe Capital on Aging or senior centers to help people be able to qualify for Medicaid, because a lot of people are under the old rule as far as you only can have $2,000 in the bank. That has gone up to $130,000 for one person. And so just really trying to give folks some practical information in regards to how to get more help in their homes.
So thanks for that. And I think many of you might know, so Medicaid is the name of the federal statute, and in California it's called Medi-Cal, because we're Californian, we always choose to be different. But it's a really good program, as Andrea said. And if you're eligible for Medi-Cal in California, then you're automatically eligible to apply for in-home support services and get that kind of in-home support. So we'll add that to the mix of things and figure out what role this committee might have in doing a presentation or something about it. You're absolutely right that the income limits just changed. There's been several changes like that in the law, which I think again is an indication of California's more forward-thinking approach to services. So thanks for raising the issue.
Yeah, and then one quick question. I don't know if there's a way that because they have increased the amount of money you can have to 130,000, if there's a way they can increase just a little bit of the income requirement, because you literally have to be poor. And if they can just increase the income requirement, it would allow other people to apply for services. And I don't know if we can do that at at a different level. So yeah.
Yeah, I think that's a legislative change.
Yeah,
and I don't actually, I mean, some of it's a federal legislative federal requirement. So it'll be interesting to see how that plays out, but helpful comment. Other people have suggested presentations for the upcoming year.
Hello, this is Dolores.
Hi, Dolores. Nice to see you.
I wanted to put in a pitch for mental health of caregivers. I haven't heard much about that. You know, the programs that have been described have been fantastic and they are filling out clear needs. But I think there is another need that isn't really being addressed yet, and that is mental health. Many caregivers are depressed. They would be clinically depressed if they went to see a physician or a psychiatrist. They're almost at that level of having a diagnosis, but we don't, what's the word I'm looking for? Identify. We don't have a way to identify, because even though the caregivers are generally, or, to some extent more included in care planning, their needs are not typically looked at. It's the care planning for the person with dementia, but not their needs for their own care, and especially the mental health side of it. So I think that would be an important topic for our committee to address in the year ahead.
Thank you. Thank you for the suggestion. A topic that's not often talked about, really, so helpful. And I think one of the other topics I've heard that might be ready for a presentation for us is in the master plan for aging, there was identified sort of the need to make long-term care services more affordable and efforts to look at mechanisms to fund that program at a state level. And I think there's some interesting work that we might want to have a presentation about in the year ahead. So we can add that to the list. We have now more topics than we have meetings, but that's okay. It'll give us lots of opportunities to choose things. Any other comments from advisory committee members about that? Okay, I think we're then ready to talk about recommendations at each of the meetings. Is that we provide recommendations to the secretary about what we heard today, what we're interested in making sure ends up in the report that the staff provides. So I will open that up again to committee members to identify topics that we want to call to the secretary's attention. Okay, well, I'm never short of ideas, so I really appreciated the discussion about the intersection of Alzheimer's and developmental disabilities and Down syndrome in particular. And I thought a lot of those comments were about identifying strategies to reduce the silos and better collaborate among the departments that have work in that area. So I think that's worthy of calling out, since all of those departments are under the Health and Human Services Agency. other people have ideas.
Could we be forward thinking and just related to the session that's upcoming? And I'm hearing discussion about budget deficits, and we just really want to make sure that we aren't facing cuts. I mean, so much incredible work is happening. We don't want to see any of that be slowed down or eliminated in any way. We want to see California continue to build. So maybe some kind of comment about that, like just despite fiscal challenges the state might be facing, we want to see continued commitment to expanding, building on the great work that's being done.
We look forward to continued commitment of building on the master plan for aging and all of the work, even in what appears to be a fiscally difficult time. So sounds great.
And I would just suggest that the pilot projects that are being outlined are really very valuable. I think one has, through a pilot, the chance to really look at some ideas, test them out on a small scale, and I'm hoping the pilots will identify the savings to the state as a result of the innovations that are being explored. It would be great to think that the research is so solid that it'll point to real financial benefits by instituting programs for, enhancing the quality of diagnosis, the care, the support for the caregivers. So I think the science behind this is really something to also emphasize the importance of.
I think that's a great comment. As someone who did work long ago in the last really bad budget time around the adult day healthcare centers and the important work that they were doing, I think the CalCompass pilots are really welcome, and it'll be interesting to see what the data from those programs show. So I agree with your recommendation.
And I just wanted to comment on the fact that the residential care homes that Todd and Kimberly talked about earlier, they are not evenly distributed throughout California. And I'm wondering if we need a task force or a subcommittee to look at what the factors might be that encourage and discourage the development and implementation of these residential care homes for individuals with the double disabilities. But I think it's remarkable what they've done in Southern California, but as was pointed out by others, it's not found in other parts of the state. So why is that? It seems like we could investigate that. That could be one of our subcommittee tasks.
And I think that I was trying to define that in a broad way. I think that's a nice subset of what I raised about how do we take the presentation this morning and foster that collaboration across departments to understand how resources that each have available can be used and then supported and additional resources developed. So I think that dovetails nicely with the comment earlier about the importance of sort of better understanding the services to people with intellectual and developmental disabilities that also have dementia and how we can improve those services. So thank you for that, Dolores. Susan.
Oh, you can see it. It's hard to see on my, I did want to just give an update on the master plan for aging before we close. I failed to mention that, but we are on track. Part of the master plan process is we submit an annual report to the legislature, and we're on track to deliver that in January. So it will be a summary of the calendar year, everything that happened in 2022. And in addition, if you'll recall, the first 132 initiatives were for the years 21, 22. So the feedback that you provided at the Cal for All Ages and Abilities Day of Action, excuse me, as well as other input, we now have draft initiatives for the next 2 years. We're looking at roughly 100 or so. Those will be released on the same day as the annual report. And we are targeting January 24th for that event. It will be public and everyone can access via Zoom when we release both of those documents together.
Thanks for that update. And we can probably do a shorter version of that announcement when we meet in February. That would be a really terrific piece of information, I think, for all of us to have and be able to answer questions that committee members might have. So maybe we can add that. The timing seems perfect for our February 2nd, I think it is, meeting. So thank you. Glad to know that's on target too. Okay, any other comments or recommendations for the secretary? Andrea.
So I did have a question. There's a lot of good programs out there, but in regards to the RFPs that go out, is there like a percentage to make sure that people with disparity and underserved community are being part of those fundings and services? Because sometimes you hear about the great programs, but you don't know what is the percentage, or is that a requirement? Is there a requirement each time a funding opportunity come up, there's a percentage of people, underserved community, going to be able to take advantage of those services? So I'm just curious to know if that's a requirement when they apply for the monies and when they are awarded, the money. Because I think Catherine mentioned that there's a community called Empire, where it was a community, a Latinx, and it was good to see funding going towards that community. So I'm just curious to know that each time funding is available, is there a percentage of underserved communities being able to participate in those funding source? I don't know if that makes sense.
It makes sense. The department has certainly a focus on equity, which would include underserved communities. And there might be somebody from the department, one of the departments, that can provide a bit more information in response.
Okay.
So Susan or Lauren, maybe.
Yeah, I can jump in for public health. So it does, like, the way it is viewed looks a little different depending on the RFP or the RFA that goes out. It just, each one has its own set of requirements. So I just want to kind of level set that expectation. But that being said, health equity and reaching underserved communities is baked in and embedded into every one of those opportunities. It is part of what we do as a department and in our branch and in this program, to be sure we're looking at those underserved communities and that they're being fairly represented in the projects that we're funding. So the exact requirement looks a little different from time to time, but that is embedded in all of our work and all of our opportunities.
Good. And is there like an oversight community to make sure that those fundings are going to those communities? Because it's one thing to have the monies available, but it's another thing to make sure that the monies are being allocated to those communities.
So we do have our branch in our program at Department of Public Health sits in the Center for Healthy Communities, which has a health equity program component that looks at all of those opportunities, who's funded, what happens with them. But we also have an Office of Health Equity within the department that looks at those opportunities as well. So we have a few different places where it's viewed and sort of ensured that it's part of work that we're doing, and that, a big part of our philosophy is what you mentioned, but is not to just provide funds to a community, but to provide funds for a community through that community, just to them, in the way that, like, oh, now this service is provided, but really to be part of that community, to fund the community, to take care of the community, as opposed to us trying to come in and be the lead on that. So I'd say there's multiple different views that look at it before any final decision is made.
Okay, great. Thanks, Lauren, for that. Appreciate it.
Perfect. And I think just the other note is the Health and Human Services Agency has an entire set of equity principles that govern all of its work. So maybe we can send those out to the link out to committee members. It's on the California Health and Human Services Agency webpage, and they really speak to exactly the issues you are, and it's to guide all of the work of the departments, not just about grant making opportunities as you've heard about, but all of the work that's being done. So really, really forward looking of California, I think. So Barbara, you had a comment.
It's actually a question. The meetings for next year, are they going to be virtual or in person?
So I think virtual is allowed through June 30th, 2023. And I think we don't know whether that's an option for after that because it was a 1-year legislative extension. That's my understanding. Do you have an opinion about what we should be doing, or you just wanted to know?
I just wanted to know. I mean, it's easy to be virtual. It's also, it's nice to be in person. I mean, there's some benefits to that too. So
yeah, no disagreement. And I just want to note that Susan added the comment that the governor's new executive order on equity includes targets, measures, and metrics. And so there's more to come. So thanks for that as well, Susan. Okay.
Could you please give us the dates one more time for 2023?
Let's just put that slide back up. February 2nd and then May 4th. I remember that right. February 2nd, May 4th, August 3rd, and November 2nd. So it would appear to be the first Wednesday of, first Thursday of every month of the months identified.
Thank you.
You're welcome.
And after this meeting, I will drop the calendar invites for all of those dates and send them all out to you. So you'll have them in your calendars.
Another reason we appreciate you, Michelle. Okay, any other comments or recommendations? And if not, we're going to allow time for anyone in the public who wants to speak in the for about 10 minutes that we have remaining. So I think we can see if there's anybody who there. So you can use the Q&A function to ask a question or select the raised hand feature, and you will then be unmuted. So perfect.
Thanks, Catherine. It doesn't look like we have any hands up. There was quite a bit submitted through the Q&A, but it looks like our panelists and committee members have been responding on and off throughout the meeting. So there's no open questions or comments. There have been some appreciation for the discussion today that was shared through Q&A. So I encourage you all to check that out. And with that, I think, Catherine, I will turn it back to you, seeing no hands for public comment.
Perfect. Thank you. Thank you so much. And I really appreciate everyone who participated today. I thought there was a lot of engaged public comment throughout the presentations, which was great to see. And all of you who answered people's questions with the expertise that you have, I'm sure that the members of the public appreciated that as well. So thanks so much. So I think we're at time for any closing comments. Susan, is there anything you or someone else at CDA wants to say before we leave?
No, just thank you, Catherine, for your extraordinary leadership, but you're just so engaged and hands-on. And I think today's agenda really reflects the pre-thought and pre-work that went into making it such a substantive meeting. Thank you very much.
Oh, you're
so
so
all
welcome.
our members, including the new ones joining.
Yeah, thanks everyone for participating, and thank you to the CDA staff. We can have lots of good ideas and they actually take shape because we have amazing CDA staff who help put the panels together and work hard to get all of the materials done on time. I think it's pretty remarkable. We had every presentation on the PowerPoint slide and coordinated, and just a really terrific discussion. So any other committee member with a last word? And if not, we're going to give you like 15-20 minutes of your day back. When does that ever happen? So thank you, everyone, and best wishes for a wonderful holiday end of the year celebrations. We'll see you all in February. Thanks so much.
Thank you.
Bye,
Bye.
everyone. Bye.
Thank you.
Bye-bye.